So I'm delighted to welcome everybody here. As Mark said, this is the 9th annual Bucksbaum Institute Symposium, but obviously the first virtual symposium. And I hope that by next year we will have a vaccine and we will be in person again, but I'm not sure that anybody's betting on that. But still, it's terrific that we can still get together under these circumstances. So I think you know that this symposium is part of a whole annual series of lectures and seminars that are hosted by the Institute. And since 2011, there have been 190 academic lectures, seminars, and symposia. So that's terrific. And a big feature of this is the distinguished keynote speakers. So all 4 advisory board members have been keynote speakers. Geordie Cohen, Hot Humphrey, Laura Roberts, and Arthur Rubenstein. So we're delighted that they're all here today. The late Dr. Sherwin Newland from Yale was a speaker. Dr. Arnold P. Gold from Columbia was a speaker. Wendy Levinson from the University of Toronto. Jerome Lowenstein from NYU and Peter Ubel from Duke. So obviously a really distinguished group of people. And this year we're delighted that Bernard Lowe from UCSF and the Greenwall Foundation is here. And Bernard certainly maintaining the tradition of eminence and excellence of the keynote speakers. So this year's symposium, there'll be research presentations from current Bucksbaum Institute faculty and medical students on topics that are focused on the doctor-patient relationship, on communication in medicine, shared decision-making, and health disparities. And then following the keynote talk and research presentations, there'll be a concluding panel discussion with all 4 National Advisory Board members. So other general institute statistics, there is a book, so you can see it there, but obviously 2021, it's the 9th symposium, but it's the 10th academic year. We have appointed 446 faculty, medical students, and undergraduate scholars, so quite a number. The faculty scholars now represent all clinical departments, so that's a big accomplishment, and obviously it's very inclusive and interdisciplinary. And 30 programs that engage local, national, and international audiences, and 119 funding pilot grants have been awarded. So a whole series of major accomplishments on behalf of the Institute that is really terrific. So at this point, I will hand it over to Mark, who I think will introduce our speaker. Mark.
Thanks so much, Ken. I'm Mark Siegler, and I'm just so pleased to invite all of you to join us for this 10th year of the Institute and the 9th annual symposium hosted by the Bucksbaum Institute. Today's symposium, as you all know, is the first one ever that is virtual rather than in person. The Bucksbaum Institute for Clinical Excellence was founded in 2011 with an extraordinary gift, endowment gift from Matthew and Carolyn Bucksbaum and from their family foundation. The mission of the Bucksbaum Institute is shown on this slide, to improve patient care, to strengthen the doctor-patient relationship, to enhance communication and decision-making in healthcare through research and education programs for medical students, junior faculty, master clinicians, senior faculty, and also to reduce healthcare disparities. Since the founding of the Institute, we have continually sought ways to better fulfill our mission. Currently, the Institute has appointed, amazingly, 446 scholars. These scholars include master clinicians, senior faculty members, junior faculty scholars, associate junior faculty, medical student scholars, undergraduate pre-med student scholars, and even a few international faculty scholars. Additionally, over the years, the Institute has supported a total of 30 programs, several of which Ken referred to, including pilot grants annual lecture and seminar series, courses for fourth-year medical students, and even an undergraduate clinical excellence program in partnership with the university's pre-med undergraduate college. Ken has introduced our extraordinary board members, Arthur Rubenstein, Jordan Cohn, Holly Humphrey, Laura Roberts. Ken himself is on the board, as well as Kay Bucksbaum and John Bucksbaum. I also want to thank the directors who partner with me in leading the Bucksbaum Institute. And they are Matt Sorrentino, the Associate Director of the Institute, and Miss Angela Pace Moody, the Center's Director. Throughout today's program, we hope that you will not hesitate to submit questions for our distinguished speakers via, this is important, the Zoom webinar Q&A function. Please use the chat function for general commentary, but not for questions directed at the speaker. I now would like to introduce my colleague and friend of many years, Dr. Bernie Lowe. After 9 years as president, Bernie Lowe, in recent months, became president emeritus of the Greenwall Foundation, a foundation whose mission is to expand bioethics knowledge in order to improve clinical biomedical research and public health decision-making and practice. Previously, Dr. Lowe was professor of medicine and director of the program in medical ethics at the University of California, San Francisco. A member of the National Academy of Medicine, Dr. Lowe has chaired National Academy committees on sharing clinical trial data, on conflicts of interest in medical research, education, and practice. And most recently, in 2019, he's chaired a committee on evidence-based clinical practice guidelines for prescribing opioids for acute pain. Dr. Lowe serves on the board of directors of the Association for the Accreditation of Human Research Protection Programs, and also on the medical advisory panel of the Blue Cross Blue Shield. Dr. Lowe and colleagues have published well over 200 peer-reviewed articles on many, many different issues. He's also the author of a book entitled Resolving Ethical Dilemmas, a Guide for Clinicians, the 6th edition of which was published in 2019. He continues to care for a panel of primary care internal medicine patients at UCSF. Dr. Lowe will now present the keynote talk for our symposium. The talk is entitled Physician and Medical Student Responses to COVID-19. Please remember to submit questions under the Q&A rather than the chat. Bernie, it's a delight to welcome you. Hello.
Mark, thank you very much for that extremely kind introduction. And I'm honored and delighted to be here. And my thanks to the Bucksbaum Institute for the wonderful work that you do. If I could have the first slide, please. First of my public, so I don't have any conflicts of interest. If I could have the next slide. Could I have the next slide, please? So I'm going to today try and cover the following. First, a historical perspective on physicians and epidemic. Secondly, the responses of healthcare workers to the COVID-19 pandemic. And third, some cross-cultural perspectives on doctors' responses. On the next slide, this is a pictorial of a plague doctor in 17th century Italy. This was the equivalent of personal protective equipment. We can talk later about what it all represents and whether it has any meaning. But it's meant to emphasize that Many doctors, eminent physicians included, Galen, Sydenham, fled the plague when it arrived on their doorstep. Next slide. And others refused patients who were ill in their cities. Next slide. There are recurrent themes in all epidemics. First, must doctors put themselves at risk to care for patients in need? And I would include nurses and other healthcare workers there. And second, what responsibilities do hospitals and governments have to protect healthcare workers who put themselves at risk to help others? The next slide, please. Let's skip ahead. On the next slide, please. Let's skip ahead a couple centuries. This is an X-ray we saw very often in San Francisco in 1983. A young, previously healthy man with extreme shortness of breath, high fevers, diffuse infiltrates tending to be more in the periphery, rapidly progressing to complete whiteout of the lungs. This was pneumocystis pneumonia and AIDS. On the next slide, the same year, San Francisco General Hospital, the safety net hospital in our city, opened a dedicated inpatient unit to the care of AIDS patients. It was totally staffed by volunteers. And just notice there's no protective equipment being used here because we simply didn't know very much then about how AIDS was spread. Next slide. There were, at the time, the practice after you did a phlebotomy was to recap the needle. And right here you can see this person is headed for a needle stick accident, an occupational hazard. On the next slide. Nurses and their unions raised the question repeatedly of, do needle sticks put them at risk? I must say, hospitals and public health departments were slow to respond. Even such things as having these disposable units for sharps were not easy to get. On the next slide. It required many years before the technology was put in place to have, for example, self-retracting needles so that the needle could not puncture the healthcare worker because it was retracted. Next slide. This is an eminent cardiac surgeon, W. Dudley Johnson, one of the pioneers of cardiac surgery. In 1987, he announced he would no longer operate on HIV positive patients. He said, quote, "The risk is too great. There are simply too many unknowns." The next slide. This is an orthopedic surgeon, the chief of orthopedics at San Francisco General, wearing a garb that she actually developed, complete face shield, gowns that were waterproof, double gloving, waterproof boots. San Francisco General is a major trauma center. Orthopedics gets a lot of emergency cases. On the next slide. There are bone fragments and blood flying around the operating room. You know, they use power drills. Glove punctures are common according to orthopedics surgeons. Several times a week when they unglove, there'll be punctures. Dr. Day said, she asked the ID specialists about her risk, her colleagues' risks, and they said, according to her, you need more blood than that. Needle sticks are nothing to worry about. On the next slide, in 1987, a San Francisco General nurse was documented to develop needle stick related HIV infection. I think that really shook people up. There was always a theoretical statistical risk, but when one of the colleagues at San Francisco General developed the needle stick infection, it really scared a lot of people. Many surgeons then started wearing spacesuits, double gloves and gowns, etc. Dr. Day went further. She wanted to test all patients for HIV. She was accused of discrimination against people with HIV not wanting to operate. And this, of course, is in the context of rampant discrimination against persons living with AIDS during that period. On the next slide, please. There was a firestorm of public controversy, escalating name calling. Prominent physicians, politicians, all jumped in. She was derided and she ultimately resigned her post and stopped orthopedic surgery. However, the equipment that she advocated now is standard personal protective equipment. And I'll show you some slides later of healthcare workers in the COVID pandemic. And you'll see that's the equipment that they would like to be wearing. On the next slide, this is C. Everett Koop, a pediatric cardiac surgeon, was appointed Surgeon General of the US. Next slide. He issued a landmark Surgeons General report on HIV, and there's a lot of interesting stories about how he was in charge of actually doing the writing and got it through the White House. On the next slide, please. He also addressed, on the next slide, he also addressed the question of, do doctors have responsibility to care for HIV positive patients? He was not a shy man. He was outspoken in his beliefs, and he was a real public health advocate. Said, quote, healthcare in this country has always been predicated on the assumption that everyone will be cared for, no one will be turned away. As a physician and an American, I'm proud to be part of a tradition of care that will not abandon the sick and the disabled, whoever they are. On the next slide, please. This was a New England Journal article in 1989 entitled When a House Officer Gets AIDS. The next slide. This was a young physician who had a Sharps injury and blood exposure in 1983. In those days, house officers actually had to do stat hematocrits by spinning the blood down in a capillary tube. And those of you who have gray hair remember how fragile those tubes were, how easy they were to break. He stabs himself with a tube that had blood from a patient who had received over 1,000 transfusions after a bone marrow transplant. He developed an acute virus-like infection that was well worked up and documented. And in retrospect, that was acute HIV. He developed HIV positivity in 1986 and developed full-blown AIDS in 1989. On the next slide, please. The hospital did not acknowledge he had contracted AIDS on the job, despite the excellent documentation. The CDC investigated his case, but again, did not report it as a case of occupational HIV infection. He lost his health insurance, he and his family. There was no disability or life insurance to take care of his family. Next slide. His case and others raised the question of, what are the responsibilities of hospitals and governments? Do they need to provide protective equipment to lower the risk for healthcare workers? And do they have a responsibility to assist healthcare workers become sick or disabled or die from occupational infection? Next slide. And skip to the next, please. So epidemics continue. This is China. Couple decades later, this is SARS. Doctors and nurses ran away from hospitals. To forestall that, the Chinese authorities basically fenced off hospitals and locked in healthcare workers, nurses, as well as patients. This is a soldier in the People's Republic Army throwing supplies over the fence to people who were living inside for their isolation. The next slide. So can we draw any inferences from these historical perspectives? I'd like to suggest that epidemics arouse the best and the worst in individual people and in society. Discrimination has been a recurrent problem throughout history. Next slide. Next slide, please. A couple of suggestions. First, risks are perceived as greater if they are novel, not understood, disturbing, out of control, and seemingly unfair. It's impossible to reassure people only with statistics. And I think it's important to acknowledge healthcare workers' risks, fears, and anxiety. I think it's also important to acknowledge uncertainty in pandemics and the evolving nature of evidence. And therefore, I would suggest the need to revise policies in the light of new evidence. Next slide, please. So now I'm going to talk about how United States healthcare workers have responded to the COVID pandemic. Next slide. This is Manhattan earlier this year. They were deluged with so many cases that the ambulances had to literally line up to get to the emergency department and unload their patients. Next slide. There were so many COVID cases, so many deaths that the morgues ran out of space. Hospitals had to rent refrigerated trucks. And here's a man with a forklift taking a dead person's remains out of the hospital to store in a truck. The morgues were also overwhelmed. Next slide. Next slide, please. Lady on the right here is the head of the ICU in a safety net hospital. And on the next slide, she said of her staff, they just take their courage in their hands. They put on their garb and they show up. Of course they have anxiety. Of course they have fear. They're human. We don't even know if we might get sick. But none of them so far has defaulted on their duty, their calling. So I think it's really summarized the sort of heroic, self-sacrificing nature of so many healthcare workers and other essential workers during this pandemic. Next slide, please. This woman is the chief nurse in the emergency department of another safety net hospital. Next slide. She said that she worked every day from 6 a.m. to 9 p.m. and stayed up usually till midnight troubleshooting problems. Because of a rather long commute, she didn't live at home. She lived in a local Best Western hotel. Once on a rare day off, she said she went home, but didn't go inside for fear of infecting her family. She waved at her children through a window. When her 7-year-old started to cry, she responded, "Mommy will be back." She just needs to take care of other people now. So many healthcare workers were really fearful of taking infection home to their families. And many developed a routine on the next slide, where they took off all their work clothes before entering their homes, threw them into the washing machine to wash, and then showered, and then cleaned off all their surfaces before they interacted with any of their family. Some self-isolated at home, and others chose to live away from home. Next slide shows an ICU physician in Colorado who put up a tent in his garage and lived in his garage in order to protect his family. Next slide. So I want to say a few words about essential workers, people whose jobs cannot be done remotely and are necessary to keep society going. And of that large group of people, I want to focus on people who have many face-to-face interactions with many people and have repeated exposure to COVID. So in addition to doctors, nurses, respiratory techs, housekeepers, patient transport, clerical staff in emergency departments, many of these workers work for low wages. They may have no health or disability insurance, for example, if they work off a registry or they're working for an outsourced firm. And many are people of color who live in crowded neighborhoods. Next slide shows the, next slide. He is the director of, I think it's called sanitation services in his New York hospital. And it's important to note that housekeeping staff often have relationships with patients that are therapeutic. On the next slide, housekeepers often spend more time with patients than physicians, and they're able to make a human connection while they're working, to listen and talk to the patients and show interest and concern. Next slide. Patients can be, and their families can be greatly appreciated. This is a handwritten thank you note from 2 children. Thank you, Dr. Devine, for helping my mom get better and for helping and saving people every day. Next slide. There are also more grown-up ways of expressing thanks. This is a group of emergency department workers who were thanked by having meals delivered to them while on call. And they're saying thank you from the medical center staff for the crowdsourced donation of meals. If you think about it, a lot of healthcare workers who worked long shifts, by the time they got off work, not only was there no place they wanted to eat, but they couldn't go to a grocery store because they were either closed or sold out of what they wanted. Next slide, please. This is an ICU nurse who talked to an investigative reporter about the emotional toll caring for COVID patients took on her and her colleagues. Next slide. Some healthcare institutions set up emotional support programs for their staff. And this particular system in Wilmington set up peer counseling. They trained peer counselors and made them available. So this is the nurse, and this is a peer counselor off nurse. These are incredibly moving encounters with lots of tissue paper needed. And next slide shows that despite whatever social distancing that people have to do, there's a human need to just acknowledge the other. Next slide, please. Next slide. I want to give a special shout out to medical students or some medical students. Next slide shows University of Colorado medical students. The background, you see the home field of the Denver Broncos. And this is a student collecting sanitary wipes and gloves from the community to give to the people working in the hospital, the University of Colorado Hospital. Next slide. This is a UC medical student sending a message to all providers. If you're in need of support right now, my classmates and I are here to help you with childcare, errands, etc. So trying to step up and help the people who were working the front lines, even though their own education was disrupted, their clinical rotations often canceled. Next slide. Next slide, please. A qualitative study was done on University of Washington students and residents. And these are some representative quotes. I'm excited to be able to make a difference, but I'm just as scared as everyone else. As strange as it sounds, I feel lucky to be working at this time. One of the residency directors said that he asked for volunteers to fill extra COVID shifts that were needed because of the steep rise in the census. And he said that volunteers filled all the extra shifts within hours of the appeal being posted. Next slide. There's a downside to this self-sacrifice. And this is a strike of nurses and respiratory techs. And this gentleman is saying, we'll work for a new N95. Many hospitals had acute shortages. Often people not only had to wear a mask the whole day, but they were given one mask every several days and asked to clean it between shifts. Next slide. These are nurses at a hospital in Los Angeles. 10 of them refused to go to work and enter COVID patients' rooms because they didn't have adequate PPE. They were all suspended. Next slide. There are lots of investigative reporters who have done in-depth stories with frontline healthcare workers. This is an ICU nurse in Texas. And on the next slide, her quote, next slide, oops. Sorry, the quote's on my cheat sheet here. She said, "We don't feel like heroes. We feel tired. We feel anxious. We feel the weight of our patients and families upon us. Aside from being a nurse," she said, "I'm also a DACA recipient." Next slide. Another nurse in Texas, another ICU nurse in Texas. She said, quote, "I feel unappreciated and unseen, both by my government and my community. Living in the South and being a Black nurse just adds on another layer of stress and debilitation during this entire situation. I feel safer in my scrubs than I do in everyday street clothes. But now, with the racial tension, I feel that even as a nurse, I am seen as, quote, one of them, or, quote, a rioter, regardless of my attire." Next slide, please. The lady on the side here is a 61-year-old physician's assistant who worked in the emergency department at a safety net hospital. It's her husband, and in the center, their daughter, who's now a college student. This woman had only a surgical mask to wear at work. She did not have an N95. And she became hospitalized with COVID. Next slide shows a tweet her daughter, next slide. Her daughter sent her a tweet. "Good morning, Mommy. It's a new day. I'm still praying for you to come home. I need you, Mommy. You're the only one who understands." You'll have to read yourselves. I can never get through this without breaking down. The woman wrote back, "Love you. Mom, be back." That's her last text before she died. Her husband said that their healthcare benefits for their family were terminated 30 days, after her death. Next slide. Next slide, please. So let me say a few words from a cross-cultural perspective. Next slide, let's skip across the ocean. This is the Wembley Arch, one of the iconic things in London. It's Wembley Field is the new Wembley Field is the home field of the English football team. That's soccer, not American football. And that's really the national sport. And they and many other public buildings put up blue signs, the National Health Service colors, and said, "Thank you, NHS." Next slide. There was something called Clap for Our Carers. On Thursday evenings at 8 p.m., people came out to the streets to applaud, to salute their healthcare workers. Next slide. Next slide. Everybody did it. These are police and firemen coming to the hospital to thank the healthcare workers. And obviously, police and fire are also putting themselves at risk for COVID and a lot of other things in the line of duty. Next slide. This thanks went up and down society. This is the Duke and Justice of Cambridge and their 3 children coming out to applaud. Next slide, please. Healthcare workers were moved. Often they would come out of the hospital and applaud back for thank you. Next slide. But there were other messages as well. This is a group in one British hospital. We stay here for you. Please stay home for us. Next slide. The editor of The Lancet wrote an editorial saying that they received a lot of reports from healthcare workers who report bullying NHS senior staff who threaten disciplinary action for raising concerns about safety, testing, and access to PPE. Next slide. This is a nurse. This is Downing Street. Sorry, you can't see the street sign saying protect healthcare workers. Next slide. In a contrast, this is the Prime Minister of New Zealand, Jacinda Ardern. And I think among the world leaders, she's probably done one of the best jobs of being an advocate for public health, the common good. She always uses that we as a community, as a nation, are going to band together to prevail. We're going to all accept limitations on what we'd like to do. The day before she announced a nationwide mask requirement, she posted a video of her and a friend who's a boxer learning how to make their own masks. Next slide, please. So let me end, because I'd like to leave time out and how the schedule is, Mark, for some questions. So a couple of take-home messages. First, responses to crisis like pandemics are shaped by emotions, risk perceptions, ideology, social norms, and ideals, ethical aspirations. Workers who put themselves at risk to help others deserve protection. Next slide. I would suggest a society should ease the emotional and material burdens that heroes bear. So to operationalize society, I would say it's healthcare institutions and governments. And finally, I think good leadership matters, and the lack of good leadership matters also. So thank you, and I hope I'll have time for questions.
Ernie, let me ask you a question. Can you hear me?
Mm-hmm.
In 1987, an orthopedist, a late doctor, Lawrence Pottinger, and I wrote a paper, the title of which was Surgeons' Obligations to Treat HIV-Infected Patients. And then after speaking with you, Chicago did not have a very high incidence of HIV patients, but after speaking with you, we did a survey of orthopedic surgeons in the 5 cities in 1987, 88, that were the leading cities in the country doing HIV. And we were astonished with about an 85% response rate from the orthopedists in these cities, indicating that 50%, perhaps closer to 60%, would not operate on a patient with HIV, even if life was at stake these are orthopedic surgeons, from the operation. What has changed things so dramatically from the HIV experience of the 1980s to the COVID experience of the last year or so?
Yeah, terrific question. It's a multifaceted answer. I think first, HIV happened to those people. That's what a lot of people thought. COVID happens to everybody. Everyone's at risk. You can imagine your neighbor, your grandparents succumbing to COVID. And that's what we saw in Italy. I think the other thing that's really changed, and those of you who are more active than I in medical education can comment on this. I think the younger physicians have made a tremendous difference. I think the younger physicians, house officers, and students are idealistic. Are they more idealistic than others? I don't know, but they're more outspoken, they're more public, and even when they themselves cannot volunteer to provide direct care, they're thinking of ways to overcome the needs that the frontline workers have. Again, those you, some of you might want to comment. I think the changing makeup of the medical school classes. I mean, there's slightly more women than men now. And I think that many of the women house officers have not only been out in front, trying to care for their colleagues, making sure that they're providing emotional care, both to patients when their family couldn't visit, but also supporting their colleagues. So it's multifactorial. But let me just stop there.
Thank you. Very, very helpful. Jordy.
Bernie, thank you very much. That was really a terrific review of what we've just gone through. You emphasize, of course, the contributions of healthcare workers and their compassion and their willingness to sacrifice themselves. But you also pointed out that there were many other employees in the healthcare system who were also putting themselves at risk and exhibiting, in some ways, the same kind of altruism and compassion and concern for others, which leads me to wonder whether or not, what is it about medicine and the health professions in general that either reinforces or amplifies what is obviously a broad base of human sympathy and empathy and concern when others are in trouble. And it also raises to me a very important aspect of what medical education is all about. Not only do we need to select people who have a proclivity and a propensity for this kind of compassion and caring, but we need to find ways to reinforce that natural tendency and make it stronger and more resilient so that it can, in fact, withstand things like COVID, which are undoubtedly going to come in the future. So your thoughts about that, please.
Absolutely. So I think that I agree with you that I think it is a natural human response to want to help someone in need. I would have liked to have said, we see it all up and down society. I also think that it's important to spotlight some of the ways that nurses, aides, custodial staff, people like that who also put themselves at risk are under even greater burdens. Many of them don't have savings. They're living just on the margin. Many of them say, even if they're sick, they can't stop working because they're the only one working in their family and they're supporting the family and paying the bills. I showed you a picture of an ICU physician able to self-isolate in his garage. Many of these other essential workers live in crowded housing with other people. They can't isolate. When they get home, there are other people there who are in close proximity. So I think we have to really be attentive to how this, I would agree with you, this universal instinct to help others plays out differently in different communities and across structural issues in the US society.
Thank you, Dr. Lowe, for a very thought-provoking and timely talk. We have some questions that have come through the question and answer that I'd like to ask.
Glad to try and answer.
The first one is a question about obligations to our trainees. I'm sure where you are as here, many of our residents and interns were frontline in taking care of the COVID patients. They sacrificed their education and they were put on more and more rotations where they were in the COVID units or the ICUs. As a healthcare society, as an academic center, what are our obligations to our trainees to keep them safe? And should we be having our trainees out of the front line?
Well, I think keeping them safe is key. And I think safety is relative. I mean, in an ideal world, people would have, frontline workers would have adequate personal protective equipment. They wouldn't have to take their N95 masks home and try and clean them. They wouldn't have to. Now you hear these stories about people having to take plastic garbage bags and cut holes in them to put on it for gowns. So I think there is an obligation. I think it's both a hospital-based obligation and a government-based obligation to mitigate the risks that those people face. So second, to follow up on the other part of your question, the education, I think it's important. I think learning by doing can be terribly helpful. Taking responsibility is extremely productive. I think the education has to continue. I also think emotional support to help those newly minted doctors and interns process what they're going for is tremendously important. I know, Mark, that many of your fellows have been working on kind of helping healthcare workers understand and process their experiences.
Another question was raised about your thoughts about hazard pay for healthcare workers and other essential workers. You know, these people are giving extraordinary amount of their time and their health. Should they be paid more? Who should bear that cost? Should we shift costs from subspecialists that are not in the front lines to ones that are in the front lines? How should we really reward these people who have done way beyond their normal work?
Yeah, it's a great question. Again, I would sort of go for the basics first. I mean, most healthcare workers don't ask for extra pay. They want safety they think they're entitled to. I think hazard pay makes sense. Who should bear that cost? I'm not sure. Let me also say many subspecialists in the high prevalence cities re-educated themselves into critical care physicians. So people learn to manage ventilators, work in the emergency room, and really go back to doctoring skills from their medical school and internship days. So I think that, and specialists are also at risk. If you think of cardiologists, invasive gastroenterologists who do procedures. So I think we have to have a broad view of who's at risk, and also realize, to go back to Dr. Cohen's question, that people are primarily motivated by altruism and a desire to help others. I think extra pay would be great, but they're not doing it for the pay. But something tangible to thank them would be nice.
There's another question about volunteers versus assigning physicians to, you know, different units. And in our institution, when the COVID numbers were increasing, we asked for volunteers to staff the COVID units, staff the ICU, staff the ED. As the crisis became more and more prolonged, it became clear we were going to run out of volunteers. So do we start assigning everybody? Should we only go with volunteers? How do we approach some physicians who also are at high risk? And how do we keep them out of harm's way?
Yeah, so my age puts me in one of those high risk categories. They told me, stay away from the hospital. We don't want you, thank you. So I think there's an intermediate step that's crucial, which is listening to, take a healthcare worker who isn't comfortable going on the front lines and eliciting, listening to their concerns and trying to address them. I think this is what the Bucksbaum program teaches in terms of the strong doctor-patient relationship. You've got to listen, you've got to show empathy, and you've got to work on a common agenda. I think many people, once they have a chance to articulate the concerns and can hear what steps are being taken to protect them, are more willing. I also think there's a big fear of being in over your head. So there needs to be a lot of technical education in service in how to do things. And a lot of things are brand new. Who knew how to do prone positioning, how to have a team that does it well? So I think it's, you know, the term I think it applies is it should be a learning experience. And we should demonstrate to the workers the same sort of communication skills and shared decision-making that we would want to see with our patients.
One of our attendees noted that some people have noticed that governments that are run by women appear to have better outcomes in their societies compared to those that are not, looking at New Zealand as an example. What do you think? Do we need a different approach from our government leaders to try to help these pandemics and help our essential workers?
Well, I think we need a different approach. I mean, I think you can also point to a lot of examples who disproportionately tend to be male, I think, whose leadership has been erratic at best. I don't want to sort of go into, dive into a sort of a gender-based dichotomy, but certainly Angela Merkel in Germany also, I think, is an example of someone who's a woman, a leader who's tried her best to steer her country through a crisis. She has a totally different style. She's a scientist, she commands the facts, she's very concise. I tend to personally think that I think the qualities that make you a good doctor with patients also make you a good politician. If you can relate to people, show you understand their concerns and their pain, and then address them, that works. And I think we all can learn from that, I would hope, regardless of our gender, how to do that better.
And then finally, how can we as a medical field learn from this? What are the major weaknesses that this pandemic has really brought out in the medical field? And what should we address before the next surge, the next pandemic hits us?
That's really the $64 trillion question. I think the one thing that we need to grapple with is the loss of respect for medical and public health expertise. I think some of that is due to hubris on the part of people who want to become public spokespeople and weren't really humble about the limitations of what they knew and didn't know. But I think, as we look, we were joking before this started that, until we get a vaccine that works, and I would say, and that people are willing to take, we're going to do a lot more of these Zoom meetings rather than in person. Boy, I miss those in-person meetings. So how can we, as a profession, interact with society and individual patients in a way that will make them more willing to follow what we think is evidence-based advice. I think to try and get people to take a vaccine is going to be a huge challenge. And I think time is now to start thinking about that.
Well, unfortunately, our time is running out. I want to thank Dr. Lowe on behalf of the Bucksbaum Institute and all of our attendees for a wonderful, thought-provoking, very timely talk and lecture. And hope that we'll be able to discuss more in the future. But we need to move on to some of our other talks. And so I will turn this back over to Dr. Siegler, who will introduce the rest of our symposium.
Thank you. Again, thanks very much. It was a pleasure to be here for 2 days virtually with you, Mark.
I wanted to thank Bernie also for a beautiful, insightful talk, very valuable information for us to learn. Thank you so much, Bernie.
Okay, my pleasure, Mark. See you soon.
We are now going to continue with the research presentations portion of the symposium. We look forward to hearing 6 talks from Bucksbaum Institute faculty, scholars, and medical students. Again, I want you to remember to submit your questions in the Q&A section. Our first speaker, I'm delighted to present, is Jay Pinto. Jay is an MD, FACS, a professor of otolaryngology and head and neck surgery. Jay completed college and medical school at Stanford and then did his residency training here at the University of Chicago. Dr. Pinto's research focuses on the causes of chronic inflammatory disorders of the nose and also in identifying genetic and environmental influences on sensory dysfunction and on aging. Jay Pinto is an investigator on programs supported by the National Institute of Allergy and Infectious Diseases and by the National Institute on Aging. Dr. Pinto, we're proud to say, is also a Bucksbaum Senior Faculty Scholar and recently was appointed, as you've heard, as Dean for Faculty Affairs in the Biological Sciences Division. Jay Pinto will now present a paper entitled Airborne Exposures and Respiratory Disease in Inner City Chicago Children. Jay, welcome.
Great. Thank you so much to the Bucksbaum Institute for supporting this work entitled Airborne Exposures and Respiratory Disease in Inner City Chicago Children. I'm Jay Pinto. I'm from the section of otolaryngology, head and neck surgery in the Department of Surgery. So asthma in the US has a major public health impact. 5.5 million people have asthma. It affects 7.5% of all children, and the prevalence has been rising in recent decades. The reason for this increase is unclear. I'll talk to you in a minute about some reasons why, but genetics, exposure to allergens and microbes, viral infections early in life, and environmental exposures have all been implicated in the development and manifestation of disease. Of all of these things, environmental exposures are potentially modifiable, and so if we could reduce exposures that cause problems, we can potentially have a big impact. There's a lot of important disparities in asthma, especially in cities. So we know that asthma disproportionately affects urban populations, African Americans and Hispanics, and those in lower socioeconomic groups. For example, children in Chicago have high rates of mortality from asthma, among the highest in the United States. As you can see here on the left, on the right, we're number 4. And many groups here at the university are working on this, including Valerie Press and my colleague Louise Giles, and people in the Urban Health Initiative, as well as regional coordinated efforts among a number of different centers, including the Coordinated Healthcare Interventions for Childhood Asthma Gaps in Outcomes Consortium, of which our institution is a member. So why might this be? Well, we know that the environment and specifically microbes can affect the development of asthma, and it's a very interesting hypothesis, the hygiene hypothesis, which has been around for many years, which suggests that the microbes in your environment when you're growing up, when you're born, can affect your immune system and can predispose you to disease. For example, exposures in the airway affect the development of asthma, as been shown by the Copenhagen prospective study on asthma in childhood, or COPSAC, where they swabbed the airway of infants 1 month after birth and then followed them over time and found that certain bacteria that were present in the airway at birth would predispose those children for getting asthma. We also know that the upper airway and the lower airway are directly exposed to the environment, and that environmental exposure can affect the development of asthma. For example, if you grow up on a farm in Europe where the barns are actually attached to the homes, then the bacteria from those animals can get on the children and can be protective. And in contrast, early viral infections such as rhinovirus or respiratory syncytial virus early in life can predispose the airway to developing a asthmatic phenotype. And these complex effects on immune development suggest that there are things in the environment that can affect asthma. What about other environmental exposures such as air pollution? Well, these things also trigger asthma attacks. So air pollution is a known trigger of asthma exacerbations and emergency room visits. These pollutants can come from traffic, from cars, they can come from industrial sources, they can be particulate matter or gaseous pollution like nitric oxides. And these things come into the airway and inflame the airway and trigger these asthma exacerbations. Microbes are another trigger. For example, viral infections are known to trigger these twitchy airways and cause asthma attacks. And this is some data from Taiwan showing the peak of asthma exacerbations in terms of ER visits totally overlaps with the red line here of PM 2.5 peak. So as the PM 2.5 levels go up, kids come to the emergency room for asthma, and as they go down, the visits go down. And so we know that this is a trigger of asthma exacerbations and hospitalizations, and so that's a major cause of this morbid manifestation of asthma. And so these triggers may also affect airway responses in terms of antimicrobial responses, antioxidant responses, and then trigger these exacerbations that cause children to come to the emergency room or be admitted to the ICU. And I'll just tell you a story. My wife had a patient in the PICU. It was an 11-year-old with severe asthma. He went to his barbecue at his grandmother's house, collapsed, was taken to the hospital, was intubated, and they did a lot of heroic measures, and that patient died. So these triggers can trigger this high mortality that we have here, and this is something we see in our institution day after day. So the questions we tried to tackle with this project was, do environmental exposures explain Chicago's high pediatric asthma morbidity and mortality, and especially these large health disparities we see? And then can we use this information on environmental exposures to improve disease on both the individual level and community levels to improve population health? Here on the right, you see the asthma prevalence by community, and you can see it's heavily weighted on the south and west sides where our patients come from and where we have high numbers of minority children. And so clearly there's some disparities there in who's getting asthma, who's being admitted to the hospital, and who's dying from asthma, and we want to solve this problem. So in our study, we sought to characterize the upper and lower airway health of 50 asthmatic children and 50 controls, ages 9 to 17, who live on the south side of Chicago. We recruited them at the Southside Pediatric Asthma Center, where Louise Giles in pediatric pulmonology and Brenda Battle are the co-directors. And we tried to test how these two major urban exposures, air pollution, PM 2.5 levels, and airborne microbes, are associated with respiratory symptoms and lung physiology and asthma. And we're trying to get at this paradox of the city being a dirty environment, so it should be protective, but nevertheless it's causing these microbes, and these exposures are causing severe disease and morbidity and mortality. So with the help of Rob Staniker, our nurse practitioner, we recruited patients at the asthma center starting in the fall of 2019. We got consent and assent from the children and consent from the patients, parents, and then we trained the child or the parents to have the child carry a portable air-beam sensor, which measures PM 2.5 for at least 6 hours a day for the 2-week period of time. And we had planned to do this in different seasons to get some seasonal variability. And these devices record air quality exposure and location, so we can actually track not only what is the exposure, but where are the children and where are they being exposed to these things. They wear it in their backpack, it's easy to use, and then at night we had them leave it in their bedroom so we could measure indoor exposures at night. And we know from other work from one of our collaborators, Brisa Ashbrook-Kilfoy, that there are actually very high levels of indoor PM 2.5, which also could be a trigger. And we know from the pandemic and that children just aren't outside as much, that indoor exposures may be very important as well. So we clinically phenotyped these children at their follow-up visits at the asthma center. And then we also had a way of measuring microbes in the air, which is a device called an Inspirotech monitor, which would sample air in the bedrooms of these children's homes to see what kind of microbes they're exposed to at night. It can collect the material on an electrode inside the machine, and then we can process that for microbiome analysis. What's interesting about that is people have looked for microbes in the dust of homes and in the bed linens and in the mattresses, but no one's looked in the air itself. And so this is quite an innovative look, because those microbes in the air, what's in the air is getting into your nose, getting into your lungs, and potentially triggering disease. So I'll just report our work in progress. We've recruited 16 subjects, 15 asthmatic African Americans, children, and 1 European American control. The mean FEV1 was pretty good. These children are at home. They're doing reasonably well. It was 83% of predicted value, although we did have a range. And then some other airway parameters, such as FEV1 over FVC ratio, was also reasonably good. But the mean fractional exhaled nitric oxide was actually quite high. So it was 45.7 parts per billion. And we think that anything over 25 to 35 is pretty high. So these children have a lot of inflammation in their lungs. Interestingly, the mean PM 2.5 exposure was 8.9. The range was very low, almost undetectable, up to 47. And to give you an idea, if you ever follow this literature, levels like over, say 14 or so are high, are elevated. So some of these children are having very high levels. We were only able to measure in 1 season because the pandemic hit. So what have we learned so far? There's very limited data, but there is some correlation, and sort of weak correlation between PM 2.5 exposure and lung physiology. So kind of weak with FEV1, but higher with FEV1 over FVC, and pretty decent correlation with airway inflammation as measured by FeNO. And then we also learned some interesting things about where our patients and where they go in space. So we can track where they go. We can see which neighborhoods they end up in. And you can see these patients are primarily from South Shore, Hyde Park, and Kenwood, and Lower West Side. You can see that where the number of our measures are. But we also see them in Washington Park and Washington Heights and Lakeview and Woodlawn and West Lawn, near South Side, Lincoln Park, and Jackson Park. So these children are traveling around, and we can kind of follow where the counts are and see where they're in high exposed areas and low exposed areas. And this might be useful because we may be able to learn, we hope to learn which blocks, which neighborhoods, which routes are high exposure, might lead to more disease, and maybe we could direct children to safer areas which have lower exposures, away from highways or away from major thoroughfares. So that could be an interesting outcome of this project. We see here you see the zip codes, and you can see this zip code 60617 has very high exposures, 28.8. And I've shown that where that is on the map, and you see there's a big highway that runs through there, and 95th Street runs through there. So along those routes, we might see high exposures. And so we can, again, use this from a policy point of view to map out where are schools, where are homes, and where are roads, and how can we get children into safer areas. So our pilot experience, what have we learned? We've learned we can recruit Chicago children and families to do this. We can get them to take the monitors. We can collect high-quality geospatial air pollution data in these children. We know that so far the exposures vary greatly and may correlate with airway parameters. And we're hoping to begin the next phase of home airborne microbe sampling. Again, this hit right when we were going to deploy this right at the pandemic. And we want to pivot now because children are in school, and our goal was to see how kids get back into school. So we're going to pivot to home exposures, which our microbe monitors can measure, our indoor monitors can measure, and then as children go back into schools, we can follow that. So in conclusion, understanding the effects of environmental exposures on asthma will allow us a range of tools to fight this deadly disease that plagues Chicago children, both through policy initiatives to reduce those exposures, biological knowledge that we can generate, that maybe there's biological tools we can use to block the responses to those triggers, and then therapies that might take into account those exposures. A community approach and a collaborative approach with a range of expertise we hope will help us improve the respiratory health of the city's most precious resource, our children. And this project is one step in the larger battle of reducing health disparities in respiratory diseases in U.S. children. So I just want to tell you our airway team. We have Louise Giles in pediatric pulmonology, Brisa Ashboy-Kilfoy in public health sciences, Brenda Battle at the Urban Health Initiative, and then we have some community partners and a nonprofit called the Environmental Law Policy Center, Susan Mudd and Tiffany Werner, who've been very helpful. They actually gave us the devices to use and have been instrumental in working for environmental justice. And so with that, I want to thank the Bucksbaum Institute for supporting this work, and I'd be happy to take any questions. Thank you.
Thank you very much, Jay, and we'll open it up for some questions. I guess the first question is, do you have any data on how well Chicago compares with other cities? Are we better than others, or are there other cities that are much worse than us, or is that data still need to be collected?
You know, so other urban cities have a similar problem, and it's interesting, even small cities can have high pollution rates, but we face very high rates of asthma and asthma mortality and morbidity on the South Side. We see this in the hospital, and those rates are high. They're among the top in the nation. Our exposures in Chicago, I think one thing you can see on that map and what we've learned and what's known about pollution exposure is that there's very differential pollution exposure in Chicago. A lot of that is related to where you are in relation to the roads and the highways. And so you can see the drop off from that in different parts of the city.
As you're collecting some of this data, are you sharing some of this data back to the families and the children to know that they may be in areas that are at higher risk?
Yeah, that's a great question. So the nice thing about our project is these patients are plugged into a system here we have at the Southside Pediatric Center. And so all of the data collection is essentially managed by Louise, who's taking care of these children. So Louise provides direct feedback about this problem that the children have to the families so they can learn about this issue of environmental exposure and avoiding triggers that might lead to, poor outcomes.
You nicely pointed out that some of the major highways may be a source of some of these pollutants, but what about some of the housing stock? Are some of the older houses, some of the houses that have mold and other things in them compared to newer communities with newer houses? Is the housing stock an issue as well?
That's another very insightful point, something we're thinking about. So, the general pollution literature has been focused on cars, on industrial sources. You see this in the news. We've got to electrify cars. We've got to get, clean energy. And we haven't thought a lot about indoor air pollution. What we've learned, what Brisa has learned from some other studies in Chicago where monitors have been placed inside homes is that home indoor air pollution levels can be terrible, crazy level she sees, on the order of particulate matter pollution in the hundreds. And so absolutely poor housing quality stock can be a source of deleterious exposures. And not only PM, but formaldehyde and many building materials that were used in the past have toxic elements. Also, ventilation can be really important as we're all thinking about this. And as we're all inside more and children are inside more, we really have to think about what they're exposed to as they're breathing at night.
In today's day and age, we're all learning how to wear masks 24/7, it seems. And you look at places like Beijing, where air pollution is really high and everybody wears masks. Do you think that can help any of our at-risk children, especially on days where pollution levels are higher if they wear a mask?
Yeah, it's a great question, and I've done some work in Beijing. In China, in Beijing specifically, many people have filters in their house, air purification systems, and people use different forms of masks to avoid this problem of high pollution exposures. I'm not sure that's been tested. Either of those have been tested rigorously in terms of ability to prevent disease. But I think as we're learning in the pandemic, some practical common sense, would suggest that appropriate use of masking should help. And as the work from Argonne has showed, even simple masks with simple materials and multiple layers can prevent SARS coronavirus 2, spread, and it certainly could potentially prevent exposure to other pollutants.
Well, thank you very much, Jay. Your work is very exciting, and hopefully it'll help many of our kids in the future. But I'll turn it back over to Mark now to introduce our next speaker for the symposium.
Thanks, Matt.
Thank you so much, Jay. It was a pleasure to have you speak. Our next speaker will be Marshall Chin, MD, MPH, who is the Richard Perillo Family Professor of Healthcare Ethics, an Associate Director of the McLean Center and a Bucksbaum Institute Senior Faculty Scholar. Marshall is a general internist whose work focuses on improving the care and reducing disparities of vulnerable patients with chronic diseases. He's leading a project at the moment to improve shared decision-making among clinicians and LGBTQ people of color. Dr. Chin was elected to the National Academy of Medicine in 2017. Dr. Chin is a graduate of Harvard College, UCSF School of Medicine, and completed his residency and fellowship at the Brigham and Women's Hospital. Today, Marshall Chin will present to us a talk entitled Humanities and the Arts to Advance Health Equity. Marshall, it's a pleasure to welcome you.
About a month ago, a dozen of my colleagues and I did a pilot intervention for the entire first-year medical school class entitled Improv and Stand-Up Comedy, Graphic Medicine, and Theater of the Oppressed to Advance Health Equity. I'm going to share what we did in this pilot and some of the preliminary results. Unfortunately, health disparities persist, and caring for diverse patients is challenging. COVID-19 and police brutality have heightened public awareness of systemic racism. We believe that the humanities and arts have potential for training students about these complex issues. The arts cut to the chase regarding understanding the human experience and connecting with people directly. The arts also may be a novel method for teaching about emotional and cognitive intelligence. About a year ago, I published a paper in JAMA Internal Medicine called Reducing Health Disparities with Improv Comedy. And Eric Topol, who's a physician thought leader who has a large Twitter following of about 300,000 persons, he tweeted out, "I can't picture you doing improv comedy, but it's a good thing he did." And we also hope to think that you might be asking yourself, what does comedy or improv or stand-up have to do with health disparities? And we hope that by the end of this presentation, you'll be saying, I'm glad they did this pilot. Our project objectives are to use principles and techniques of improvisational and stand-up comedy, graphic medicine, and theater of the oppressed to improve education about care of underserved populations and promote equity, diversity, and belonging. Our specific learning objectives are to humanize clinicians and patients, to improve listening, observation, and empathy, and to recognize how diverse patients perceive you and how you perceive them. A long-term goal is engaging in free, frank, fearless, and safe conversations about structural racism, colonialism, and social privilege. Our main goals for this pilot were the first 3 bullets. Our intervention was a 3-hour module within the required first-year medical school course, Health Disparities, Equity, and Advocacy. We divided the 3 hours into two 90-minute sessions. They were done in small groups, about 10 students per instructor, using Zoom. And each student was randomly assigned to 2 of the 4 art forms: improv, stand-up, graphic medicine, and theater of the oppressed. On the far right is one of my personal heroes, Monica Vella, who was the course director for Health Disparities, Equity, and Advocacy. And she kindly gave us 3 hours in her curriculum. And time in the medical school curriculum is more valuable than the King's Gold. And so you may be wondering, why did Monica allocate 3 hours of her course? Monica understands how difficult it is to have conversations about interpersonal biases, systemic racism, and social privilege. And she also recognizes how difficult it is to provide students with concrete practical skills about these interpersonal biases, about navigating the complex bidirectional biases that exist between clinician and patient, and how complex it is having these difficult conversations around systemic racism and social privilege. For each of the 4 art forms, the session started off with a discussion about safe space for the discussions, then a number of exercises from that art form, and then discussions relating the exercises to caring for diverse patients and advancing health equity. Here's our crack team of the 5 improv instructors. 3 on the right are University of Chicago faculty who are experienced with doing medical improv. And Nikki Orlov, who will be one of the next presenters talking about a separate project, Jen Rusiecki, and Sandy Toon. Bottom left, that's John Stoops, who's a professional. He's the theater owner of The Revival, the theater here in Hyde Park. And upper left, that's Jamie Dolan, who is a physicist and a communications expert. He actually co-founded the improv team I'm a member of, and he is currently based in the UK at the University of Cambridge, a very talented, funny man. So Angela and I are going to demonstrate one of the improv exercises the team did, called Yes Circle, which was designed to improve the trainees' listening skills, ability to build relationships, and empathy. Okay, so can we have a suggestion of an object you might find in a home, like a chair or a sofa?
A table.
A table, I hear table. So I see a brown table.
I see a brown table that has a glass top.
I see this table with a glass top that's brown, and there's some chips out of one of the legs.
Yes, and one of the legs is a little shorter, so the table leans just a little to one side.
Right, and on this leaning table, I see carved into one of the legs, the letters K-I-T.
Huh. There's also a napkin and some other utensils on top of the table.
Yes, and I see a bottle of wine on that table too, and some candles.
And I see a piece of fruit.
And scene. So you see that Angela and I, we're trying to listen to one another, and we're not denying each other's realities. We're building upon each other. So it requires us to listen and to build a scene together of this table. For stand-up, Mona Abermishan and I led this particular session. Mona is a professional stand-up comedian and one of my stand-up teachers. She's a Palestinian-American Muslim stand-up with extensive international performance. We focused our stand-up session on recognizing how others perceive you and how you perceive others. The main exercise was a personal monologue. We had the students think for about 5 minutes and journal notes for the following 3 questions. How do others perceive you when they meet you for the first time? What do they get right? What do they get wrong? And then we had volunteers do personal monologues, maximum 90 seconds each. So for example, so after people get to know me for a while, they fairly frequently say, Marshall, you're a lot more interesting than I initially thought, which is their kind of way of saying, Marshall, when I first met you, I thought you were boring as hell. I mean, like, give me a no-dose before I speak with you, Marshall, or better yet, one of those ring pillows so that I don't hurt myself when I speak with you. You know, I think part of it is that I'm a pretty even-keeled guy, that I don't have a lot of highs or a lot of lows. but I think part of it is the Asian face. If they see me and they say, this is probably a boring science geek, or, you know, do you know Bruce Lee? Or this is an Asian gangster. What they don't see below the surface is the person who knows a pathological amount about the National Football League. I could have intelligent conversation with probably any fan from any city about their particular team. Or they don't see the guy who was the feature, the headliner, at a stand-up show at the Field Museum that featured scientists who do stand-up. So you see then that if a half dozen students share their personal monologues, you have a lot of rich material then to look at issues of identity, of issues of perception, issues of biases. So it's a springboard for some rich discussions. Graphic medicine was led by Brian Callender from our faculty, as well as Shirlene Obobui, who was one of the medical residents. One of the exercises they did was called the mirror, where they asked the students to then draw pictures of their professional identity, their personal identity, their context, and community. So this is one of the drawings that I did from a different workshop of Brian's on graphic medicine. And there are two obvious things from this drawing. First, that I do not have any particular artistic skills in drawing. Your kindergartner could do a better drawing than myself. But then second, it doesn't matter the quality of the artistic drawing itself. This particular drawing, I was representing myself there in the middle. To the right there is my wife, and my left my son. The red stethoscope is to identify as a physician, as the books, my academic identity. And then below on the bottom, the three blue structures, below me, that's supposed to be a map of the United States. Below my wife, who's Japanese, a map of Japan. And below my son, that blob is supposed to be China, representing him as a Chinese, Japanese, American. My mother is the woman at the top of the diagram. And furthest away, that's my father, who passed away a couple years ago. So he's closest to the sun. So you can see how this drawing would be an entree in discussing a variety of aspects of my identity. Theater Press was led by Dorian Miller and Angela Pace-Moody from the Bucksbaum Institute, with assistance from Monica Peak and Monica Vella. The pre-session homework for the students was to create a scenario involving at least 3 people and a conflict in which someone is being oppressed. This is a picture of a conference in India that was co-sponsored by the Bucksbaum Institute. And this was a conference where the instructors were actually teaching Angela, Monica Peak, and I about theater of the oppressed. And in this format, what happens is that they're in this scenario in which a conflict arises and someone is being oppressed. Anyone from the audience, and we all called spect actors, anyone in the audience could interrupt the scene and say, I'm going to take over now, and then replace one of the actors, and then role play how they would enact that role for that person being oppressed to try to help them get out of that oppression. And then following the scene, there would be a discussion among the audience as we all discuss what had happened and what was effective in terms of then trying to get out of that oppression. So Angela and I are going to do a demo of Theater of the Oppressed. The scenario is that Dr. Khan is a surgical attending, and Dr. Pierce is an African-American surgical resident who grew up on the South Side. Dr. Khan says she supports Black Lives Matter, but wishes that these people would just stop trying to kill each other. They need to get a job or go to school. Why can't they do something useful with their lives, like you, Dr. Pierce? So how does Dr. Pierce respond? So Angela's going to give a first crack of what she would say if she was Dr. Pierce, and then I'll give it a try also. This is a simplified scenario. We'll just play Dr. Pierce as opposed to multiple actors in the scenario.
Dr. Khan, these people? I don't understand when you say that to me. You know what? I'm sorry. Why don't we go ahead and finish this case, and maybe afterwards or tomorrow, let's sit down and have a conversation, because I would really like to share with you some personal insights about why I think Teddy's in this current circumstance and why he has found himself in our OR today.
Stop, and now I'll stand in, and I'll be like the spect actor giving a crack at being Dr. Pierce. So Dr. Khan, I've really enjoyed this rotation with you. I've learned so much from you, and I have so much respect for you as a surgeon. But to be honest, I feel uncomfortable with what you just said about our patient, Teddy. That it makes me uncomfortable, the beliefs or values that you're assuming about Teddy. And so I'm wondering if you could help me understand sort of what you were meaning there. So you see, like, there's no right or wrong answer to this, that this is a difficult situation for anyone to be in. And so the whole purpose of Feel Your Press is to have everyone like give it their best crack at what they think might work if they were in Dr. Pierce's shoes. So you can see that then it leads to a broader class discussion about what are the issues raised and what might be different techniques that could be most effective. And you can see that there's no right or wrong answer here, but the purpose is to basically see how different people might try to do the role of Dr. Pierce in real life, and at least in a discussion then of what people thought might be effective if they were in Dr. Pierce's role. So our evaluation involves surveys. They were like quantitative rating questions and open-ended questions, and then qualitative interviews. Lauren Peterson is doing the qualitative interviews. Meng Chi Ju is our crack statistician. And I'm going to share some preliminary results. These are the first wave of responses, with currently a 56% response rate after the first wave. And keep in mind, this is a required course for all the first-year medical students, not an elective of people who chose into this elective. On the scale, 1 is low, 5 is high. And you see that most of our questions centered around about a rating of 4, so high around 4. So the overall rating of the course, if students were to recommend the course to others, students became a better listener, more observant, if they felt good about themselves during these modules, if the modules helped them bond with the class. The highest rated question was establishing a safe learning environment, 4.6. So the vast majority of students felt the learning environment was safe and that they could take risks. And then interestingly, about a quarter of the students felt stressed during the activities, which we actually thought was probably a good thing, that they felt safe, yet they felt stressed, because discussing these issues of systemic racism, privilege, these issues of diversity, are complex and can be stressful. And there's a famous Martin Luther King quote talking about the need for a constructive tension for us all to move forward. I'm going to now share some qualitative quotes. So improv. We recognize that no matter what experiences or backgrounds people bring to the table, it is crucial to listen, observe with respect, and respond in a way that is accepting and open-minded. It made me understand that there are a lot of different ways to actively listen to people, not only by hearing what they are saying, but by interpreting their body language. Similarly, I learned how my own words and body language could be portrayed by others. Finally, it taught me the importance of affirmation for a patient's thoughts, experiences, feelings, by practicing the yes and method. This was such a fun experience. I was nervous about it at first because I do not like acting and can be a bit shy, but this was definitely introvert friendly. Dr. Rusiecki was phenomenal. Really enjoyed this experience and would definitely recommend keeping it as part of the course. Stand up. This module encouraged self-reflection and vulnerability in a way that felt both safe and fun. It was truly engaging, and I felt that it lent itself especially well to self-insight. This module made me reflect deeply on how difficult it is to separate others' perceptions of me from my own identity, and how assumptions can have a huge, often harmful impact on people. It made me want to really be conscious of the things I say to people about themselves, because I never want to have a negative impact on how someone feels or their identity. I like that this module made us get uncomfortable in a safe space and reflect on questions about perceptions and assumptions. It was also really fun to be a part of it. I love Mona's energy. Graphic medicine. She, Dr. Obobwi, was so supportive and encouraging of all our ideas. I also liked how the exercises they used, creating a 2-panel comic, forced us to think of simple ways to communicate complex ideas about structural inequality and healthcare disparities. It forced me to really boil the issues down to root causes, which was very informative. It made me more aware of different healthcare inequities that other people have observed, and also made me think about how to depict these things graphically. Very good discussion, which was led by the students. Really insightful and great atmosphere to discuss these topics. A great session. This allowed us to think outside the box and participate in a unique activity. Theater of the Oppressed. I was able to take on a role in this module that is a position that I have never been in, and it's a position that I most likely will not be in. To have to navigate that outside perspective was a challenge, but also made me think more about relationships and experiences in a way that I haven't been able to do before. This is something that I will take with me to future interactions. I loved how the module helped me to think critically about the situation by placing me within it, depersonalizing the situation, and knowing that we were acting it out was helpful to have a critical conversation about what was happening, what we could do, and what we could make the scenario better. Practicing these things was super helpful to think about what I might do in these situations in the future, but also to understand how people encounter oppression on a daily basis. I really enjoyed adopting different personas within the healthcare setting. It was interesting how even as M1s who haven't been in these healthcare scenarios and hierarchy before, we knew the pits and traps of each character, and it helped us to navigate the situations with greater nuance. I think they were very productive, and my classmates and the facilitators brought up some incredibly insightful points about how actors could have done better to address the inequities. So some suggestions for improvement: it felt too short. I wish that we'd had more time to dig into the later exercises. There wasn't much discussion about specifically devoted to structural inequities, but more about interpersonal communication, which was very valuable. I would have liked to participate in more dialogue about the oppressive systems that function in theatrical performance and what effect this delivery has on their perception. So in summary, the arts pilot was well received. The students believed that these were engaging, experiential, thoughtful exercises. And it was evidence that even early first-year medical students within the first 2 years of medical school were ready to benefit from this training. The next steps are a formal evaluation, so we're doing more survey waves and formal qualitative interviews. Next year, Monica Vela has devoted 3 3-hour sessions into the Health Disparities curriculum. And then we're currently revising a Macy Foundation grant application. The initial reviews were that the Macy wanted pilot data, and then one of the reviewers was skeptical that these art forms would work well for reducing disparities. So, Holly Humphrey, I know you're listening to this. The Pritzker students have spoken. Big thumbs up. They want more of the arts in the equity curriculum. Thank you very much.
Thanks a lot, Marshall. It's fascinating work, a little bit outside of what many of us probably do. And so I guess the real question is, I think you've shown this potential for young learners, but what about those of us with the gray hair now? What about the faculty who have been around for a while? Can we learn from this as well? Is there something that somebody who's been in practice for 20, 30 years learn from this? And if so, when can we start doing this with the faculty?
Well, certainly, I think anyone can learn from this. And frankly, you know, we have such great Pritzker students that sometimes by the time they finish like the disparities course and all, they actually, you know more than the residents and many of the faculty on these particular issues. And so it'd be great for all of us to learn more. All of us can get better at these issues.
From this pilot and from your involvement in improv and what you've been doing, is there one lesson that you've learned that you now can apply to your patients when you see your patients in your office, in your clinic?
Well, in many ways, like the key skills are Bucksbaum skills of being really good at listening and being able to understand how you perceive others and what implicit biases you bring. But it's also bidirectional, that patients bring biases of us as clinicians. And it's that complex interaction that's really the key. And so experienced clinician becomes a master at that, of being able to size up the biases that go both ways through good listening and putting themselves in the patient's shoes.
There are so many, issues of health disparity that we see every day, and yet many of us are so reluctant to bring them up with our patients, mostly because we just don't have, I think, the skill or the knowledge. Do you think these techniques can help us to better relate to these issues, better bring these issues to the forefront, better be able to speak about these issues with our patients?
Certainly. I mean, think, for example, that example of the simple table example where Angela and I were sort of building upon each other. If we take the clues that patients say and ask those questions that are open-ended and build upon that clue, we're eventually going to get to somewhere good. I mean, one of the improv principles is that maybe the most common mistake is that we're not listening and we're trying to think of that witty thing to say next in our scene. Whereas if we listen to our patient, we build upon what they say, just like an improv, the scene will get to a good place.
And a final question from a member of our audience, really pointing out that this person hadn't seen this used for focusing on disparities specifically. Are there any unique challenges or problems during this pilot? Are there potentials for students can be offended or unhappy with something that can happen because, in an unstructured situation, almost anything can be brought up and talked about, I suppose?
Sure. We were concerned about this possibility also. And Monica Vella's course overall, separately, they have a lot of discussion about respectful civil discourse, safe space, which we repeated at the beginning of each of the different art exercises. And so partly, it's a culture where we have great students who are open-minded and are respectful of one another. I think one of the challenges we had was then thinking about how do we sort of translate generic skills, like generic improv listening skills, to this particular issue of health inequities. And I think this is something we'll continue to develop over time. Some of the forms that are more natural for it, like Theory of the Oppressed, maybe is the best example where it was designed to do. And I think there are going to be ways for all the art forms to do that also.
Well, thanks, Marshall. I'm sure we'll be hearing more about this. And actually, our next talk will go into this subject a little bit further. I'll turn it back to Dr. Siegler, who will introduce our next speaker. Thanks, Marshall.
Marshall, thank you so much. Our next speaker will be Dr. Nikki Orlov, an assistant professor of pediatrics, associate program director for the pediatric residency training program, a co-clerkship director for the Pritzker School of Medicine, and a Bucksbaum Institute junior faculty scholar. Nikki is a graduate of the Pritzker School of Medicine and did her residency and chief residency here at the university. Dr. Orlov completed an MPH at Columbia University and graduated also from the Emeritus program, the Medical Education Research, Innovation, Teaching, and Scholarship Fellowship program here at the university. Dr. Orlov is a pediatric hospitalist and has a strong interest in teaching communication skills. Nikki is focused on improving medical training with the goal of improving patient care and patient experience. Today, Dr. Orlov will present a talk entitled Using Improvisational Theater to Improve Student Communication Skills. I'm delighted to present Dr. Nikki Orlov. Nikki.
My name is Nicola Orlov, and I'm an assistant professor in the Department of Pediatrics. I'm the co-clerkship director for the pediatrics clerkship here at the Pritzker School of Medicine, and I'm an associate program director for the residency program in the Department of Pediatrics. I'm honored to be here today to speak about my Bucksbaum Institute funded project, Improving Advanced Communication Skills of Pritzker medical students through an improvisational theater elective. It is no surprise to everyone in this room that communication is the cornerstone of the doctor-patient relationship. In medical school, we rely on direct observation, feedback, and role play with standardized patients as a way of teaching about communication. Teaching about some of the more complex and advanced communication skills still remains a part of the hidden curriculum. Research has shown that conversations surrounding death, sexuality, drug use, and suicidality remains particularly difficult for students despite receiving didactics and an opportunity to practice with standardized patients. Over the past 10 years of my career as a clerkship director and inpatient attending, this has become alarmingly clear. Our students learn exceptionally well how to gather in H&P. They have excellent communication skills and know how to follow the traditional script that we use when gathering patient data. However, in my experience, when the patient's response veered off the expected course, students often get stuck. I notice this most with the HEADS exam, which is the system that we use in adolescent medicine for gathering a social history. During this part of the history, we ask questions about drugs, sex, depression, and suicidality. The students know the prompts well and can follow the script. However, if a patient responds with a concerning answer to one of these questions, the students often get flustered, They stumble on their words and they don't know how to respond. Rather than listening actively, responding intuitively, and being in the moment, they were focused on what the next question was and what was on the checklist, and they often don't know where to go next. Improvisational theater offers a unique solution to this problem and an innovative way of teaching advanced communication skills. Advocates of improv boast that it builds communication, critical thinking, creativity, and collaboration. Emerging work in the field also suggests that improv can hone nonverbal communication skills, active listening, teamwork, and professionalism among medical students, and can decrease their performance anxiety. Further, research has found that the use of improvisational theater is well suited for members of the millennial generation because their most common learning style thrives in an interactive, fast-paced environment that fosters social collaboration. Thus far, however, scholarship has focused exclusively on the student's self-assessment and enjoyment. No one has tracked objective outcomes of improvisational theater in communication skills. In fact, Watson and Fu's 2016 study stated that, quote, initial reports mark medical improv as an area rich for future outcomes research with standardized patients and randomized groups of trainees to assess whether it measurably changes skill and behavior. Before we move on, I would like to highlight that while improvisational theater can be funny, the experience has so much more depth than just enjoyment. I'm going to ask you to suspend disbelief while you listen to these 6 rules of improvisational theater. As we go through these, it will hopefully become clear why these elements are so critical in medicine and in caring for patients. Rule number 1, don't be fearless, be courageous. More than anything else, adults are afraid of public speaking. Improv teaches you to be courageous and to help fight the fear of public speaking. Rule number 2, listen, truly listen. If you don't listen, you'll miss what was just said and lose your listener's trust. And we aren't talking here about passive listening, we're talking about active listening, where you pay attention and focus on what the other person is saying, not on what you plan to say next. Rule number 3, say yes more than no. In working with patients, in working with colleagues, and in any work that requires collaboration, yes will always get you further. Conflict slows progress, agreement creates opportunity. Rule number 4, don't be clever, be vulnerable. Rather than being strategic in planning for the next step, listen to those with whom you are working. Communicate authentically and show your vulnerabilities. Rule number 5, trust. Trust yourself, trust others, trust the unknown. And finally, rule number 6, the truth is always in the patient. When you're too attached to a plan or a storyline, you aren't paying attention to what's going on in the moment and the needs that your patient is expressing. The truth is always in the moment, and the truth is always in the patient. So back to my research question and how I got here. A few years ago, I decided to take an improv theater course at the Revival during my free time. With every class I attended, I kept thinking to myself how much this would benefit my students, my residents, and my colleagues. I started brainstorming and started doing a lit review, and it quickly became clear to me that what was missing from the field was someone to answer the question of whether improv objectively changes the communication skills of medical providers. With that in mind, I applied to Bucksbaum for a Junior Scholars Grant and was lucky enough to receive the funding to answer my above question. Research question. Can an improv theater course for MS1 students show objective improvements in their communication skills as measured by the use of standardized patients? So in talking about the course development, I would love to say that it went as smoothly as the road here on the right, but it didn't look like that. It was more of a road with lots of twists and turns and a few road bumps. After hearing from Bucksbaum that I received the funding, I applied to APPD, which is the Association for Pediatric Program Directors, to be a part of their LEAD program. LEAD is a nationally recognized program that allows junior faculty to learn from seasoned pediatric educators. Over the course of my year at LEAD, I worked together with seasoned faculty members on this project idea, and they mentored me and gave me feedback on how to develop the best elective possible. I then took the elective to the Pritzker School of Medicine and applied to the curriculum committee to receive approval to start this elective. That too was less straightforward than I expected. I thought I would apply and I thought I'd get accepted. But it took a few go-rounds in order to be accepted, and in the end, the feedback that I received really helped the program and the evaluation be much stronger than I had initially planned. So the design of my course. The way that this finally played out was that I received approval and decided that the course would best be suited for a small group of 20 students. I opened the enrollment and quickly filled to full capacity. One of the challenges, however, was that I needed to recruit 20 controls in order to have an equal intervention and control group. With the funding of Bucksbaum, I was able to provide financial incentive and somehow was able to fill those spots as well. I asked all 20 students to go through a pre-assessment phase, to go through the class, and then to go through a post-assessment phase. During the pre-assessment phase, the 20 students and the 20 controls were asked to fill out a self-evaluation or a self-assessment of their communication skills, their confidence, and their adaptability. Additionally, all of 40 of those students went through a standardized patient encounter. In each of those assessments, we used validated tools. The 20 controls were left to the rest of to the spring quarter of their first year, and the 20 students in the course went through a 9-week elective that was designed by me and a Second City facilitator, and that was also run by me and a Second City facilitator. And then, after completion of the course, the 20 students who had been through my elective were then asked to complete the standardized patient encounter a second time, a different standardized patient encounter that was also focused on a high stakes encounter. And the control students were asked to do the same. And then finally, all groups were asked to recomplete the validated self-assessment tool. I'm not going to share the full curriculum with you, but this is a snapshot of 1 week. As I mentioned, the Second City facilitator and I spent a bunch of time on the front end developing this curriculum, and we really focused on the skills that we wanted each of the students, or all of the students, to learn during each of those courses. We then tailored activities to the class objectives and the learning needs of medical students specifically. This is a video of one of the days. Well, on the left, we have a video of one of the days in the course, and on the right is just a photograph. We'll share this video now, and then we can talk about it at the end.
I know. I was just like, oh my god. Like, it looks really good.
I'm so excited to see it. Are we going to see it at Harper? We're going to slow down for a second.
Okay.
We're going to slow down just a little bit. Okay. I want you to stop right here. Okay. You don't need to touch anything, but you are going to feel some cold water.
This must be the water.
Okay. So just lean forward a little bit. Okay, walk a couple steps forward right there. Okay, now lean. Okay, walk one step back. Great. Now lean down. Okay, one step forward. There you go. Perfect. Now lean down a little bit more. A little bit more. A little bit more. A little bit more. You're so close. Now take a drink. If you are so close. Just a little bit.
Great. So A couple of things. One, as I watched this video, I realized I should have warned you. It is actually a little bit alarming to watch this video now that we have lived in the era of COVID for 6 months, because I don't think we've seen this much intimacy and closeness with people who are unmasked. So this was definitely filmed pre-COVID. The other thing I'd like to say is I really didn't film much of the course because I really wanted to respect the privacy of the patients, of the students, and let them be focused on the experience. I did receive approval from these two students to share this video. I will say that this video does highlight some of the things that we were trying to teach, which is really focusing on nonverbal communication skills and some of the advanced communication skills. It certainly is not the best demonstration of how improv can improve those skills, but it is a small glimpse into how the course went. So now we'll focus on the outcome data. Pritzker collected some data, as they do with all their courses, on how the students felt things went. And as you can see here, although our response rate wasn't high, the students felt like the course went really well, and across all measures that were asked, the majority of the responses were at 5s. One student said, "This was a great class, and I looked forward to it every week. Hearing Dr. Orlov's clinical anecdotes as they related to activities was very helpful. But in terms of relating to our own experiences, I think it would have been better to discuss interprofessional relationships, research mentors, etc., since as first years, we really have very little patient experience so far." I thought that was really helpful feedback because we are so focused on patient and clinical care encounters in our course as we relate the interactions back to patient care. And it turns out that sometimes this was hard for the students to relate to. As many of you, I'm sure, are hoping to hear, the next slide should be focused on the outcomes of the SP data and the self-assessments. However, I'm not going to share those today. Our N is very small, and our data does not show statistical significance yet. One thing, though, as we move into our question and answer period, is really, I would love to hear from the audience and the experts in the audience about how to best test these skills. We used the validated tools that are used in our Clinical Performance Center, and we used a tool that was focused on professionalism, communication, confidence, and adaptability. However, it's not clear that those are going to be the best ways to measure these outcomes. We hope after the next year of data collection to then share our final results. So I'll spend a minute talking about limitations and next steps. COVID has been a really big limitation for us. We spent the first year of our project, or we had the first year of enrollment in our elective during the 2018 to 2019 academic year. However, our elective had to be canceled, along with all other Pritzker electives, had to be canceled last spring. And so we weren't able to collect a second year of data. As we look into the future as well, I worry about how this will work in this coming academic year, because I doubt we'll be able to get 20 students together in a room. And if we end up having to do this remotely, there will be some confounders there as well. Some of the other next steps that I wanted to mention is that as a part of the Bucksbaum Institute funding, I was able to receive funding to go to the Northwestern 7th International Medical Improv Train the Trainer workshop. And the goal there really is to be able to further disseminate this work. To rather than relying on my amazing facilitator from Second City, who I was able to find, to be able to do this work by myself, and to be able to take it to clerkships, residents, faculty, and to collaborate with other of my colleagues like Marshall. Thank you, and I'd be happy to take questions now.
Thank you very much, Nikki, for that exciting project. I really love to see the students stumbling around. That was great. The question is really mirrors what one of your students asked you. Why did you decide to focus on the M1s when they haven't had a lot of patient contact or patient interviews yet? And do you think a program like this could be expanded to like the M4s, where they can hone their skills before we teach them all the bad habits?
Yeah, that's a great question. Thanks so much. So there are really only two opportunities at Pritzker to capture students and to work with them over an extended period of time. It's in the spring of their first year or during their fourth year. And so we spent a lot of time actually troubleshooting this on the front end and trying to decide which group would be best to work with. And we decided to go with the first years because they are so early in the development of their communication skills that we thought we would be able to see the largest impact there. We also knew that we would have a 3-month period to work with them. And we thought that that was going to be really important as we also spent time thinking about what the appropriate dose response was. With fourth years, you really only can capture them for a period of a month at a time.
So you chose a 3-month or 9-week program. And since you've worked, with some of these groups, I suspect it takes a long time to learn these skills. Is there a ideal period of time? I mean, Marshall showed us a program which is kind of a 1-day session. Would sessions throughout the medical school 4 years be better, or is there kind of a dose that is the perfect amount?
I think you're hitting the nail on the head. I think that's a part of the question that we're trying to answer. It is really unclear. Certainly in just one small 3-hour, 1-hour session, you learn the skills and it becomes clear how important it is to listen to the person with whom you are communicating rather than thinking about sort of the next thing that you plan on saying. But we don't know what that right dose is. And I was hoping to sort of begin to answer that question through this elective to identify if in 9 sessions we really were able to get them there. And I don't know that we have the answer yet.
Right. One of our questions from the poll here is, what role would or does emotional maturity play in how well medical students develop, into compassionate physicians and surgeons?
That's a good question, and we tried to get at that as well. On our self-assessment, we collected a bunch of demographic data, and as a part of that demographic data, we asked the students to identify what their previous career trajectories have been, what the other confounders in their lives have been. And as we looked at our data, we found no differences between the students based on previous careers or having been married or anything else. So I don't know that we have an answer to that yet either.
But we're going to look forward to see how these curriculum change our medical schools in the future, if we can ever get back into our medical schools. But I think we'll move towards that. So thanks very much, Nikki, for this presenting this work. And I'll turn it back to Dr. Siegler, who will introduce our next speaker.
Thank you. Thank you, Nikki, so much. Our next speaker is Dr. Andrew Davis, a professor and associate vice chair for quality in the Department of Medicine. Andy is board certified in both internal medicine and in public health. He's an outstanding practicing clinician educator with research interests in quality improvement, prevention, and chronic disease. Dr. Davis earned his MD from the University of Chicago, Pritzker School of Medicine, completed his residency at the University of Iowa, and earned his master's in public health from the University of Illinois in Chicago. Andy Davis is a section editor for practice guidelines for the JAMA journal, was a visiting scientist at the CDC, and has led management programs for a managed care population of 400,000 individuals. Today, Dr. Davis will present a paper entitled, "Can an evidence-based approach improve the patient-physician relationship?" With that background, let me introduce Dr. Andrew Davis. Andy.
Hi, when I was first asked to give this talk to the Bucksbaum Institute Symposium late 2019, early 2020, I really thought I had something to talk about. I had seen a paper that I was asked to review from the Stanford group with Donna Zollman and Abraham Verghese. The paper was on the physician practices to foster physician presence and connection with patients in the clinical encounter. I said, great, that sounds like a great topic for the March conference. Did some initial reviewing of it, and then I, along with Adam Sifu and Tony Lembo at Beth Israel Deaconess, were asked to write the commentary to accompany the article. That article appeared on January 7th. And you can see the basic approach. What they did is try to take an evidenced approach, look at the physician-patient interaction, and by that come down to a distillation of a few key practices that would help enhance that. I loved it because it was evidence-based, and here at the University of Chicago, we like an evidence base. So to give you some sense, at the next slide, you can see that they looked at over 21,000 clinical references. They had 73 articles that met criteria for inclusion. They looked at Oxford level of evidence and picked the highest quality research. 40% were from the United States, 60% were international. About 52% reported health outcomes. Now, the fascinating part of this paper, it was a very detailed paper with lots of supplemental materials that were also published. They looked at the systematic review and synthesized that evidence. They also did observations in primary care physician-clinic interactions with primary care physicians who were widely regarded as excellent in by their colleagues. They did qualitative interviews with physicians, and particularly interesting, they looked at 30 non-medical professionals with, quote, intense interpersonal interactions. Now, what would that be? It was folks like firefighters, chaplains, social workers, people in frontline reporters. And they looked at these practices of presence as well from outside the lens of simply a medical practice, which I thought it made it particularly intriguing. At the next slide, you can see what they started out with. They had about 30 practices initially, which you can run down the list. So it's a variety of things. It's things like presence, touch, empathy, caring, and they distilled this down to 18 practices and then assigned 13 of them to a Delphi panel, a panel comprised of a number of people of diverse socioeconomic backgrounds and experiences. I enjoyed the paper and said, gee, how in my own practice can I improve these, deliver these principles of greater presence, focusing on the patient in front of me, making eye contact, asking about them as individuals and not simply as conditions. But then something happened. January 7th, this paper came out. And then here's something from the World Health Organization, which reported a pneumonia of unknown cause reported in a hospital in Wuhan. I had actually been to Wuhan with Renslow Shear, and we had interacted with the clinicians there a few years before. But it was like, that was interesting. I wonder if this is going to be a bigger issue. And then we all know it has turned into an enormous issue. So we're now approaching, of course, 35 million documented cases worldwide, coming up on 1.5 million different deaths in the United States. Probably 210,000 people have died, and most people think that's undercounted. So the thing that happened rapidly after that is we began to shift how we physically interacted with our patients. If you look here, this is a photo of the moon suits that we began to interact with our patients. You had teams that most of the team would stand outside the door and not actually be with the patient. We had this thick glare. I did some shifts in the emergency department. And that lower left, you can see how I tried to understand what the patient's expressions were, how they were feeling through this barrier, literally a barrier. And we had these heartbreaking stories on the top right of people dying with COVID, with loved ones not being able to interact with them. So we moved to the lower right-hand corner. You can see that our interactions increasingly became remote, digital, using a telephone at first, and then increasingly video conferences. So I began to wonder, gee, how did these factors that Stanford reported on presence, what did that mean for the things they distilled as being important to an excellent patient-doctor communication? The other thing that quite quickly happened is we began to look at the differentials in mortality rate. This is work from Nancy Krieger, who's a professor of social epidemiology at Harvard. And at different periods, you can see the enormous initial spike in mortality, particularly in Black Americans. And then if you look towards the right, as time progressed, we increasingly saw increasing rates of death in Latinx populations. So all the social inequalities and the disparities that I think virtually all of you in the audience have been long aware of just had the shockingly bright light shone on them. I looked at some of the articles. Returning to the article, there's the importance of touch of the patient. There's how you interact with the patient. These are some exemplar statements that came from different parts of the review process. And I began to think, how do I do this over a telephone call only, or how do I do this with a video visit? And in our commentary to the initial paper in January, we pointed out that there are a lot of things that go into excellent health outcomes beside the patient-doctor relationship. You want somebody with good technical skills. You want somebody that follows up on lab and imaging tests. But it's undeniable that feeling cared for is a central part of successful outcomes. So with that, I came back down to, let's look at the 5 things that they distilled. But something else happened. What else shifted during 2020, March 2020, when we were going to first have this meeting? Well, we've seen the stark disparities in COVID mortalities, but we've also seen an organic social justice movement triggered in part by police violence, but also by so many years of worse health outcomes, from life expectancy to maternal mortality, HIV. COVID is only the latest and perhaps the clearest example. And we've also seen that indifference to the lives of people in color writ large, exemplified also in the deaths of George Floyd, Breonna Taylor, and Ahmaud Arbery. So initially, thinking back to how I was thinking about this talk in January, what had been an academic evidence-based exercise for me to look at the patient-clinician relationship, a topic dear to all of us in the Bucksbaum Institute, and something I've striven to do better in my 30 years of practice, became something broader. After the protests in Minneapolis and Portland, there was a facile, reactionary, and too often smug and frankly infuriating retort that all lives matter. Granting an assumption of good faith on the part of people making that comment, the COVID death toll in the United States has really sharpened how I think about that rhetorical response as I prepared this short talk. All lives do matter, including the 40% of COVID deaths occurring in nursing homes, which are often proprietary, woefully understaffed, lacking in even the most basic personal protective equipment. All lives do matter, including the lives of those imprisoned, where 7 of the 10 largest institutional outbreaks of COVID have taken place. All lives do matter, including the immigrant workers in the meatpacking and agricultural sectors critical to America's food supply. And all lives do matter, including the essential home, healthcare, and grocery store workers who work without sick leave or ability to work remotely. So I return to the 5 presence principles that were put forth by the Stanford group. And initially, when I was thinking about this, I was saying, gee, what are some small things? If I'm working on Zoom, I try and put the patient's image right below the camera on my laptop, so I have a sense of looking straight into their eyes. I try and work out the technical details with my staff in advance to have the best possible connection. I try to be intentional in my dress, in the background, the sound and light that are occurring around me when I'm with the patient. And I try and control interruptions, be that phone, pager, kids, pets in the background as you're trying to interact and have that sacred interaction with your patient. I also try and do preparatory MyChart or email messages to set the agenda, which is one of the important things, to work with the patient and agree what's important to them, what should be discussed. And I try and use that implicit invitation into their homes. A remarkable thing for many of us is to see the background, what's on the wall, how is the place decorated. Sometimes family members who would never make it to the office visit can hop on to the video visit. So that's been a gift and something that we need to treasure and use with dignity. I think another thing I've found is that video visits tend to have a linear nature. If you're stacked up and having 1, 2, 3, 4 visits, where in the clinic I could bounce back and forth between rooms, I lose that ability. One trick that has been useful for me is occasionally, if I'm running behind, I'll ask my 10 o'clock, can I call you this afternoon or early this evening? and keep people online. That's something that I I had more flexibility when I was in an in-person clinic. But the last thing I did is, I initially focused on that loss of the physical shared space, as you can see by my initial comments, as the main difference after that 7-month delay this conference has made. And you can see that those initial comments are mainly technical. However, the last line of the Zollman paper means much more to me than it did when I first looked at the paper. And the last line talks about systemic level interventions to create an environment for the implementation of these presence practices. And that issue of how do you connect with the patient's story means much more to me when I think about the factors and what COVID has done and magnified the issues that has brought so clear to the attention of this country. So even now, if I return to that last line in the initial Zollman-Verghese paper, I think what they meant was they had taken a pretty much office visit frame for that recommendation. I simply do not think we can continue to think that narrowly. Thank you for your attention, and I welcome questions.
Thanks a lot, Andy. I think you've really pointed out how difficult this world is now that we're on video with so many of our patients. I guess one of the first questions is you mentioned that this paper tried to really look at a evidence-based medicine in the best way to get to the doctor-patient relationship. Do you think that this particular issue can be studied evidence-based? Is this more a subjective way of looking at things, or are there ways that we can do more of the basic type of science approaches to these questions? You're on mute, Andy.
Okay, it was interesting to hear Marshall and Nikki talk about the importance of active listening in the improv, and in a lot of ways the principles that they distilled after looking at 20,000 articles came down to active listening, and so I think it's useful to do the evidence base. It's what we do as academics, but I think the whole reflection of the 7 months is there's a call now, a need for more of a radical empathy, to put it better. If I'm going to put myself in the patient's shoes and I'm going to ignore all the societal things that impact healthcare, it's not. I think one of the best things I saw was recently on the October 12th issue, David R. Williams and Lisa Cooper, who are giants in this field at Harvard and at Johns Hopkins, talked about something called reparative justice. And both of these authors are known for their academic, intellectual, evidence-based, methodically and meticulously put together materials. But the things they're asking for are not a question of how good was the systematic analysis and what were the p-values. They call for reparative justice through investments in early childhood education, for financial assistance to higher education and vocational training, for debt forgiveness for student loans and expanded employment opportunities. And then they talk for things like equitable access to loans for mortgages and businesses, transparent and equitable public safety and criminal justice practices, and universal access to healthcare. So yes, the evidence base is important, but I think we've got to get outside the clinic and think about all these factors in a way that I'm pleased to actually see our medical center and many others are beginning to take into account this. But it's a need for that rigor not to be simply applied to how good was the study. Are there any limitations in the limitations section of the paper that we've just written? But it's broadening the scope of what we do. And fortunately, at the University of Chicago, I think we've got the blessing of a School of Social Work, a business school, crime lab, and a lot of other things that can help us begin to marry those two, that activism as well as the rigorous science.
One of the 5 things the Stanford paper mentioned was exploring emotional cues in our patients. Do you think you can do that by Zoom?
You can begin to get there. I think it's harder on the telephone. As some of my psychology and psychiatry colleagues have commented that it can be done. It helps to have had a primary care relationship to start with, because I have some sense of their normal manner, their normal anxieties. I think it's trickier when you're meeting a new patient, but Zoom, I think, is an advance over telephonic. And as I say, you do have that extra glimpse into the folks that are at home and their surroundings at home.
And as a last question, do you have any sense if your patients actually like video visits? Do they feel that they're getting well attended to, or are they getting zoomed out and want to come back in and see you?
I think we're going to move to a hybrid model where some things are done very well by Zoom, but there are times when you need to bring them in and listen to that chest, or check that abdomen, or listen to that heart murmur, things that can't be done well on Zoom. But I think many of my older patients with disabilities have actually welcomed this as a complement to standard medical care. And I'm hopeful that we will come out from this with a mix and not simply revert to the old practices.
Great, Andy. Thanks so much for your insight on how our life has changed in this day of COVID. We have to move on to our two student presentations, and Dr. Siegel will present the students now. Thank you, Andy.
Thanks. Thank you.
Thank you so much. The first student is Daniel Ahn, a third-year Pritzker medical student and a Bucksbaum Medical Student Scholar. Daniel graduated from the University of Chicago in 2019.
I think it went pretty well.
With a
No, I'm
just biology and a minor in human rights. He worked as a researcher at the Hastings Center in Garrison, New York, on access to dialysis among undocumented immigrants with end-stage renal disease. Daniel has served as president of the Asian Pacific American Medical Student Association and helped organize the University of Chicago's inaugural Asians in Medicine conference in 2018. Under the mentorship of a Bucksbaum senior faculty scholar, Dr. Milda Saunders, Daniel will now present his research on the topic, Exploring Drivers of End-of-Life Care Views of African-American Dialysis Patients with End-Stage Renal Disease. Daniel, please.
Hi, thank you for joining us. I want to thank you for joining our presentation. I'm really excited to talk about my research that I did last summer with Dr. Milda Saunders. And our project's title is Advanced Care Planning for African American Hemodialysis Patients and End-of-Life Care Preferences. So in the United States, more than 700,000 people suffer from end-stage renal disease, and more than 30% of this population are African Americans. Currently, the adjusted ESRD 5-year survival rate is only 42%, which is actually lower than many of the cancers that we have. Because of this, there's a lot of research looking into the benefit of end-of-life care discussions because they address fears about symptoms, they can strengthen relationships with caregivers and family, and they can also provide patients with more autonomy over their care. However, African American ESRD patients are less likely to have discussed their end-of-life care preferences with their providers, less likely to have any knowledge of hospice care, and they're more likely to prefer life-extending treatments compared to their white counterparts. To look into this more, the purpose of our project is to identify what factors among African American hemodialysis patients are associated with previous experience with end-of-life care discussions, their desire to have end-of-life care discussions, and what their views on life-extending treatments are. For this project, we approached and consented 101 adult African American hemodialysis patients at 3 dialysis units associated with UCMC. We administered several survey instruments, and these included questions about well-being from the FACET-SP instrument, questions about end-of-life care scenarios from a publicly available advanced care planning workbook called Your Life, Your Choices, and questions about prior end-of-life care discussion experience from the National Kidney Foundation. And from this data, we performed descriptive statistics and multivariable logistic regression models. So for our first slide, I wanted to tell you about the patients who have had end-of-life care planning experience. So out of 101 patients, only 32 patients stated that they have had at least one end-of-life care planning experience with their healthcare provider. And I wanted to direct you to 2 important data points here. And here, for the first one, it says that less than 20% talk about end-of-life care regularly with their healthcare provider. And this is concerning because people's values can change over time. Sometimes one end-of-life care discussion is not sufficient to fully go over and understand a patient's values. In addition, only 40% of patients want to talk additionally. This is also concerning because there's research showing that patients, when end-of-life care discussions are done well, actually want to talk furthermore with their providers about end-of-life care. Out of the 101 patients, nearly 70% of patients stated that they have never had end-of-life care discussion experience. And nearly 95% of this population states that it's because their healthcare team never talked to them about their end-of-life care. Now here we see that almost 40% of patients in this population want to discuss end-of-life care with a member of their healthcare team, but have never had an end-of-life care discussion experience. And this is concerning because this is a large group of patients who are willing to have discussions about their end-of-life care preferences, but because they have not had a chance with their healthcare provider, they haven't had any of these discussions. For this slide, we are showing associations between views on life-extending care and different covariables, such as their demographics. So on the left-hand side, we see some of the covariates that we included in our models, and we asked patients 3 separate questions about life-extending care. So the first question is, do you believe it is always wrong to withhold treatments that could keep you alive? The second question we asked was, do you believe it is always wrong to stop treatments that could keep you alive after they've been started? And the last question we asked was, do you believe it is wrong to withhold treatments given through, to withhold nutrition given through tubes even when terminally ill? For the purpose of our project, we stated that if patients said yes to any of these questions, that indicated a preference for life-extending care. If they said no, that indicated no preference for life-extending care. Now, there are a lot of numbers here, and the numbers here represent odds ratios, meaning likelihood of preferring life-extending care. So I want to direct you to 3 important numbers here, and they are all less than 1. They're statistically significant, and this shows us that patients who have had end-of-life care discussions with their healthcare team or their family members are less likely to say yes, or they're less likely to prefer life-extending care, which is an interesting result. We also asked patients how they would respond to 12 common end-of-life care scenarios, and I'm more than happy to explain what the scenarios are in the questions section. So we divide these 12 scenarios into 4 categories, 4 thematic categories, and they are increased dependence and disability. The second one is a decrease in cognitive function. The third one is severe pain. And the last category was burden to family. And the last box there is a separate scenario that we asked patients that was relying on a breathing machine. The y-axis shows the proportion of patients who stated that any scenario involved with these thematic categories is not worth living. So for example, for the first box here, almost 35% of patients stated that any scenario in which they would have increased dependence and disability was not worth living. We did an analysis with this, and we found that the proportion of patients who said that increased dependence and disability was not worth living was significantly higher than that of the other scenarios, or the other thematic categories. So for conclusions, most patients reported never having any end-of-life care discussion. Most of these patients are actually open to discussions if asked, but they're just unwilling to initiate these conversations. An additional finding is that most patients report that withholding life-extending treatments is always wrong, but it shows that past experience with end-of-life care with family and or medical team might be associated with less preference for life-extending care. Finally, situations where patients would have increased dependence or disability are unacceptable. As a result, if we structure future advanced care planning to focus more on the impact of life-extending care on patients' independence, that might be more effective for future discussions. We have some potential solutions that we wanted to raise. One research shows that in dialysis clinics, there's a lot of providers are unclear about whose responsibility it is to start these conversations. Our suggestion is that frontline clinical staff, such as dialysis technicians who have close relationships with their patients, can first gauge patients' interest in ACP, and then, if they're interested, direct them to nephrologists, social workers, or MPs that are available at the centers. And then a problem that we have discussed here is that end-of-life care discussions are not commonly happening in the ESRD population, particularly among African Americans. These should be incentivized to overcome clinical inertia and competing clinical demands. And this is a big struggle here. So one potential solution is for ACP discussions and documentation to become a reported quality metric in the CMS's evaluation of dialysis clinics. I wanted to thank Dr. Milda Saunders, my mentor, for leading me through this project, Akila King, our social worker, the patients and staff at the Kenwood, Stony Island, and Woodlawn DeVita dialysis clinics, and Bucksbaum Institute, as well as the NFKI for supporting this research generously. Thank you. I'm happy to take any questions.
Thanks a lot, Daniel. A couple of quick questions. Your study focused on African-American end-stage renal disease patients. Do you know if there's any data that suggests that other groups would have similar outcomes outside of that population you studied?
Sure. There's a recent article published in the Clinical Journal of the American Society of Nephrology. It's Romer et al. They actually did this similar kind of study specifically in white population with end-stage renal disease. And they found that many of these patients also don't have access to end-of-life care. However, at a significantly higher rate than in our population of Black patients. Also, similar to our study, they found that maintaining independence, specifically in end-of-life care scenarios, was the most important health outcome and priority for these patients. So that was similar to our findings.
Do you have any information on using things like healthcare durable power of attorney for patients, which can outline patients' end-of-life wishes, you know, in an actual document?
Sure. So in our actual survey, when we asked patients if they have any end-of-life care documents, we would ask them about power of attorney forms, specific living wills, any kind of documentation. We all grouped that into one category. The main limitation of our study is that we actually did not confirm that patients had these documents. And we just simply asked them if they had these on file. And if possible, we would confirm with the actual social worker at these units to make sure that these files were existent. But we didn't do that for all of the patients that said yes.
And finally, do you have any data that if faith or religious preferences would have any impact on these questions?
Yeah, absolutely. So in our Facet SP survey instrument, it's actually dependent on 5 scores of well-being. So the Facet SP, as a reminder, is a score from 0 to 156. And the higher you are, it basically states that you are at a better state of well-being. And right now it's based off of emotional well-being, social well-being, functional, physical well-being, as well as spiritual well-being. So we did ask many of these patients, all these patients, about how they were in terms of their faith and their spiritual well-being. And we found that patients did not have a significant difference in their spiritual well-being, whether or not they've had an end-of-life care discussion. But an interesting result was patients who have never had an end-of-life care discussion actually had a higher overall well-being score than those who have had one. So that was interesting to us because we would assume, or it kind of led us to think that maybe patients don't have end-of-life care discussions or don't want to have them because they are at a higher level of well-being and simply don't think end-of-life care discussions are necessary at this point in time.
Thanks a lot, Dan, and Dr. Sieg will introduce our next student. Thanks, Dan.
Thanks, Dan. Our final student is Kevin Chung, third-year student at Pritzker Medical School. Kevin received his BA from the University of Illinois at Chicago. In addition to his pursuit of becoming an excellent physician, he's driven by making healthcare more accessible and reducing financial problems for patients. Kevin focuses on the allocation of scarce resources in the delivery of patient care. He will talk to us on the topic, the impact of the new heart allocation system on transplant program practice. Kevin, please.
Hello, everyone. Welcome to my presentation. I know this is the last one of the day, but thank you for coming. My project is the impact of the new heart allocation policy on the treatment of United States adult heart transplant candidates. I was working with Dr. Parker, who mentored me for this project. So what I want to accomplish today for this presentation is I want to inform you how the heart allocation policy is doing. It was recently updated in October 2018. And finally, I'm going to briefly mention how a simple change in the heart allocation policy can make this policy even more fair. So let's start with a clinical vignette. Your patient is hospitalized for a congestive heart failure. The patient needs a new heart, and the only definitive treatment is a heart transplant. We can temporarily give him treatments to hold him over until the heart transplant, but he definitely needs a heart eventually. That's the only thing that will save his life. So what do? So hearts are a scarce medical resource. As you can see by the orange line and the blue line, the number of hearts added to the wait list always lags behind the candidates added to the wait list, which is the blue line. So there is always a lack of supply of hearts. So in our patient's case, he will have to wait on the wait list for a while until he gets a heart. In the meantime, what treatments can we give? So before we talk about that, the heart transplant policy depends on the premise that if a patient has a higher urgency for a heart, they require a heart sooner or else they will die. So we have the treatments listed on this slide, includes ECMO, intra-aortic balloon pump, inotropes, etc. So as we see, status 1A, that's the most urgent status. The patients on that status will get the heart the soonest. The patients on status 1A have higher urgency for a heart, and treatments like ECMO given to the patient will allow the patient to get a heart sooner. So in our case, let's say the patient's heart has not deteriorated enough for intra-aortic balloon pump or ECMO or other intense therapies. So the team is considering administering an IV inotrope, such as dobutamine. So what do? So we have 3 scenarios on what we can do. So if the patient wasn't receiving this inotrope, he would be status 2. However, if he is status 2, the median wait time for him would be 630 days for a heart. He might die in between this time, so we have to consider our options. The second option, with his current dose, the patient is given status 1B. The median wait time is now 301 days. And finally, the third option is we can admit the patient to the ICU and administer a high dose of the drug and monitor his cardiac performance. He would then be status 1A, and the median wait time drops to 110 days. Now, as a physician, you gotta balance what is best for the patient. Getting a heart sooner would obviously be better for the patient, but also you have to think about if this patient gets a heart sooner, that's also potentially taking a heart away from someone else, potentially who needs it more than our patient right now, who would be stable on this inotrope on an outpatient basis. So many physicians appear to have this dilemma and possibly have overtreated their patients, which explains the blue curve. So the blue curve is the number of status 1A patients. So the percentage of these patients have increased from the low 20% to all the way to the mid 40%. And this conflicts with the rules set out by the Organ Procurement Transplant Agency, which sets out that there shall be a sufficient number of categories to avoid grouping together patients with substantially different medical urgency. So in response to these concerns, the Organ Procurement Transplant Agency decided to make a new policy. So first of all, as we see, the old policy had only 3 statuses. The new policy has 6 statuses. So this allows for further stratification of candidates from only 3 to 6 statuses. And this hopefully will allow candidates to be stratified more into their medical urgency. Additionally, some of the treatments have moved into which statuses they were, notably high-dose inotropes, which were previously the highest status, status 1A, are now all the way to status 3. So in our study, we created 2 cohorts. We created a pre-policy change cohort. patients that were listed from December 1st, 2017, all the way to April 30th, 2018. Then the policy change occurred October 18th, 2018. Then we took another group of patients from December 1st, 2018, all the way to April 30th, 2019. So in order to code our patients, the patients were listed as status 1A, 1B, and status 2. That doesn't exactly line up with the new policy change. They only have status 1, 2, 3, 4, 5, and 6. So we did a little of coding to recode these patients into their respective status in the new policy. So what we found is that the new policy is not really working as intended. So the predictive status distribution was not equal to the observed. Generally, what we found is that there were a higher percentage of status 2 candidates, which is a relatively high priority status, and then a lower percentage of status 3, 4, and 6. So generally, we found that we see a greater number of high priority listings than predicted. Now, what might be causing this? So treatments dictate what status a patient gets. So we looked at that. So ultimately, it was changes in treatment practices that altered the statuses. So the figure is there's a lot going on there. So let's focus on the left-hand side, the text first. So basically, we see an increased percentage of candidates listed with therapies favored by the new system, like ECMO, which increased by 1.2%, intra-aortic balloon pump, which increased in usage by 4%, and the granted exceptions increased by 12%. In general, we also see a decrease in percentage in candidates listed with therapies deprioritized by the new system. So treatments that grant a least favorable spot on the wait list, such as low-dose inotropes, which decreased by 18%, and high-dose inotropes, which decreased by 3%. And you can see that observed over time in our graph. On our x-axis, we have time, and on our y-axis, we have the number of candidates listed. And each color of the line corresponds to the treatments used to justify that candidate for that status. So in conclusion, there were an increased number of candidates listed with ECMO, intra-aortic balloon pump, and exception requests, and a decreased number of candidates listed with high or low dose inotropes. And those inotropes are now, it confers a status that is less favorable to the candidate. And we see an increase in the number of candidates listed with treatments that give them a high status. So what is the clinical implications of this? So on one hand, physicians, their primary obligation is to be an advocate for their patients, which is dictated by the AMA Code of Ethics. On the other hand, we have this rule set out by the Organ Procurement Transplant Network that states organs should be distributed over a broad geographic area as feasible as possible. So physicians have this duty of navigating these rules, and sometimes they conflict with each other. So it's very hard for physicians to manage this. In addition to being an advocate for their patients, physicians might have another reason for getting their patient a higher status than he or she deserves. Getting more transplant volume allows a physician to get better insurance contracts, and also it increases the reputation of that transplant program. So overall, we need a different solution to how we allocate hearts. One solution that we would recommend our team is having a transplant score similar to what is done for lungs and liver. That would allow us to objectively determine how urgent a candidate needs a heart transplant versus other subjective methods such as a physician deciding what the candidate needs. Similar things have been done in particularly France, where they have moved from a treatment-based heart allocation system to one that focuses on the candidate's overall health. And it will be interesting to see how that works out. I would like to thank everyone for listening to my presentation, my co-authors, my data sources, and the Bucksbaum Institute for financing this project. On the right-hand side, there's a QR code, which is a link to the paper we published about this project. Thank you very much.
Thank you very much, Kevin, for presenting your work. I guess one question that comes immediately to mind is, does this new allocation affect mortality on the wait list? Is that shifting or changing?
Yeah, so our project did not really focus on mortality. It was more in regards to seeing if treatment practices would change as a result of the policy, which it did. But other studies, for example, one by out of Minnesota, I think, Rebecca Caldwell found that waitlist mortality did decrease, but found an increase in death or graft loss at transplantation post-policy. But the study, I think, overlooked the important non-informative censoring assumption of the Kaplan-Meier estimator. So further studies in the future have showed that the post-transplant mortality or graft loss is comparable to the pre-policy.
Thanks again for presenting this work. I think it's important to look and see how we do things and make sure that we're doing it as equitably as possible. We're running a little bit out of time, so I'm going to switch back to Dr. Siegler, who's going to introduce our board to us. Thanks again, Kevin.
Thank you.
Thank you. Thank you, Matt and Kevin. Thanks to all our presenters for their superb presentations and to Matt Sorrentino for the questions. Each year we bring a symposium to a close by having our final discussion with the incredible members of our advisory board, Arthur Rubenstein, Holly Humphrey, Laura Roberts, and Jordan Cohen. We'll start today with Dr. Rubenstein, and I'll just say a few quick words about Arthur. He's professor of medicine at Penn. He'd been the executive vice president of the Pennsylvania Health System and the dean at the Perelman School of Medicine from 2001 to 2011. And previously, Arthur had served for 4 years as dean of the Mount Sinai School of Medicine. And previous to that, he had been the Gustav Levy, he'd been the Lowell T. Coggeshall Distinguished Service Professor of Medical Science and the Chair of Medicine here at the University of Chicago. I learned most of what I know by working as a faculty member when Arthur Rubenstein was our chair. Dr. Rubenstein is a great endocrinologist and well known for his inspired teaching. He served in many professional leadership positions during his career. Let me see if Arthur can say a few words.
Thanks, Mark. Can you hear me okay?
Yes, beautifully.
Yeah. So, of course, I'm the only one without a tie, so I hope I don't get too dinged for that. So forgive me. The best compliment I can give to this meeting is usually after about an hour on Zoom, I'm zoomed out. But here we are 3 hours later, and I found Bernie's talk and then the faculty and students at the University of Chicago inspiring, interesting, wonderful, and captivating. So I couldn't say more words of praise. I listened to every talk with great interest and admiration. So I want to compliment you all on an outstanding job. A couple of points I'll make. It's hard after all these really interesting and insightful talks to pick out a few things, but let me just say a couple of things that resonated with me. First of all, the importance of leadership. Bernie commented that in the end. We talked about women leaders in New Zealand and Germany, but maybe we didn't give it enough emphasis probably because of time. It seems to me in all these things that leadership is critical, and the type of leadership, of course, is even more important. Diversity, more women leaders have been shown to enhance institutions, companies and organizations, and we have too few of them. We could spend a whole lot of time talking about that as to why and what to do about it, but it's a really challenging and important problem. And I do want to stress that because it can make a big difference. Second point I'd like to bring up is the repeated importance of informed listening. I was really pleased to hear that. I'm a great believer in that, and I see it was stressed many, many times in the talks today, and I'm both supportive and admiring of that. One of the things that didn't come up that I would just like to put forward and hope that we would consider that is, how do you listen to people with very different and opposite opinions of yours? Mostly we listen to people who we empathize with, we have minor differences with, we can think about how to relate to them. But the most difficult thing, and it's come up, of course, politically now, which I don't want to discuss in detail, but how do you listen to people and give them the credit rather than derogation when they have very, very different opinions of yours? How do you not look at them differently, interrupt them, give them the feeling that they're less worthy and so on? I think it's a big problem. There are no easy solutions to it, but if you just read newspapers or listen to the TV or social media, which I suppose we should all listen to these days, and you hear people with different opinions, how do you really listen carefully and try to understand their point of view and what they're saying, and not react immediately negatively because they seem to be so outrageous or so on? It's a challenge, and informed listening is just the beginning, I think, of that kind of thing. The last point I'd make is I was really intrigued and impressed with all the work on improvisation and so on. One of the most powerful things that I've come across in the last 6-8 months is listening, of course, to people talk, which is listening, but mainly also to people talking about their experiences in a meaningful way that are different from ours. I'm sure many of you have listened to Black parents talking about their fear for their children when they go out and so on. These are not, these are personal things, and they have the biggest impression in many ways. And I think you're doing some of that in the improv, but I would just recommend you think about how do you present some of these things there that are so painful, difficult, and challenging, but they make lasting impressions when one looks at it. And you may be doing that, in which case I'd be admiring of you. If you're not, I would think about how you might incorporate that into these very original and creative courses. So I'll stop there. I compliment you all. It was a really great afternoon. And one of the reasons I went first is not because I'm probably the oldest, is that right, Mark? But I do have another Zoom meeting in about 10 minutes, and Mark was kind enough to let me go first. So congratulations and thank you.
Mark, you're still on
mute. Yeah.
Sorry. All right. I'm sorry. I wanted to thank Arthur so much and say our next speaker is going to be Dr. Holly Humphrey, president of the Josiah Macy Jr. Foundation. Dr. Humphrey serves also as the chair of the board of directors for the Kaiser Permanente School of Medicine. Before joining the Josiah Macy Foundation, Dr. Humphrey was the Dean of Medical Education here at the Pritzker School of Medicine from 2003 to 2018. A national leader in medical education, Dr. Humphrey has held other leadership positions, such as the chair of both the American Board of Internal Medicine and the American Board of Internal Medicine Foundation. Dr. Humphrey is a graduate of North Central College and of the University of Chicago School of Medicine, and completed a postgraduate training at the University of Chicago. It's a pleasure to introduce you to Dr. Holly Humphrey. Holly.
Thank you, Mark. It really has been such a treat to spend the afternoon with all of you and to hear about the amazing work that you are all doing. But perhaps the thing that is especially meaningful to me is the way you all began this afternoon. And you began by pausing for just a moment to recognize the important milestone that this particular meeting celebrates. And it celebrates the 10-year anniversary of the Bucksbaum Institute. And so I wanted to simply begin by thanking Kay and Matthew Bucksbaum and the Bucksbaum Family Foundation for the vision and the inspiration that they had so many years ago to create this institute, and to have had a front row seat for so many years to see this institute get launched, and now to come back and really hear firsthand the work that you're doing is a special treat for me personally, but more importantly, to just imagine the impact that you are having on the faculty, the residents, the students, and most of all, the patients and families on the south side of Chicago. The other thing that stood out to me about this 10-year anniversary is, as Mark read the mission statement, and then we had a chance to hear about all of the work this afternoon, it's very clear to me that you are meeting every single element of that mission statement. And I hope you all feel really proud of that. It was certainly inspiring to see an organization that is doing the kind of work you're doing so broadly and so deeply. I loved the talk by Bernie. We could talk about that for a good deal longer, but I wanted to highlight just 3 themes that I thought were cross-cutting throughout the talks this afternoon. The first is the importance of safety. And Bernie brought that up in terms of the healthcare providers and first line health professionals and others, environmental service workers, food service workers, et cetera, having access to PPE, so for their personal safety. But we also heard about safety in terms of safe spaces for first-year medical students being asked to engage in personally vulnerable situations. Both Marshall Chin and Nikki Orloff, I think, gave really beautiful examples of the importance of safe spaces for learning. I think we also heard very clearly, and it was mentioned by my mentor and role model, Arthur Rubenstein, and that is the importance of disparities. That's part of your mission. I think it came across very powerfully in the talks, and boy, Andy Davis, you really took your original work to a whole new level by the way in which you were able to elevate and illustrate the disparities issue. And I think both student presentations did that as well. I don't know if you're familiar with a term that I have learned recently, and it's not necessarily the most precise, but it is helpful conceptually, and I'll share it with you and for those of you who may not know about it, and it's the term syndemic. And a syndemic is the term that was actually developed by Merrill Singer in the mid-1990s to try to describe the confluence of 2 epidemics when they come together and actually create potentially more harm because of the way in which they interact. And so I think the background of the very serious issues related to racial justice combined with COVID-19 in many circles is being referred to as a syndemic. And I think that the work that was presented here this afternoon illustrates that beautifully. Let me conclude by just sharing one little anecdote, and let me ask your forgiveness. as I describe it, but my youngest child, 22-year-old, has been going stir crazy, as I'm sure many people all across America are going stir crazy. And she finally persuaded her father and I to let her take a camping trip with a friend to the national park. And so she got her tent set up and slept for the first night at Yellowstone National Park. And the following morning when I woke up, there was a text message on my phone, and the text message said, and I'll read it to you, "Mom, I have never seen stars like this before. The night sky is absolutely magical." And of course, that brought a smile to my face, because all of us who've seen that kind of a night sky, especially in the western part of this country, know exactly what she's referring to. And that made me think about you and the environment in which all of you are working and learning. And sometimes when you're as close to it as you are, you may not see it. And sometimes it gets clouded over by the other things that come up in your day-to-day work. And I know those are very real challenges. But I just want to point out to all of you that you live and work and care for patients in a truly remarkable and unique learning environment. I have spent the time since I've left the University of Chicago trying to analyze and identify the characteristics of your learning environment. Because they're unique and because they're special, I would like to see them promulgated across the country. And Kay, I hope that the Bucksbaum Institute, in fact, will be one of the vectors, one of the ways in which that might spread nationally. Thank you.
Oh, thank you so much, Holly. That was lovely. We will do our best to try to achieve what you want us to. But of course, your 15 or 16 years as the director of the medical student program didn't hurt very much. It was fabulous. Our next speaker is going to be Laura Roberts, who serves as chair and the Catherine Dexter McCormick Memorial Professor in the Department of Psychiatry and Behavioral Sciences at Stanford University School of Medicine. Laura is an internationally recognized scholar in bioethics, psychiatry, medicine, medical education, and is identified as the foremost psychiatric ethicist in the United States. If I'm not mistaken, over the years, Laura has written about 20 books. Laura Roberts has performed a series of studies on the ethics of research and clinical care in the context of serious mental illness, focusing primarily on schizophrenia. In the past year, Laura also was appointed as the chief editor of the journal Academic Medicine. She has received numerous awards for leadership and teaching, including the Lifetime Achievement Award from the Association for Academic Psychiatry. It's a delight, Laura, to have you here and to introduce you. Thank you.
Yeah, thank you so much. And I want to begin by reinforcing the wonderful comments that Arthur made about leadership and listening and creativity in our work, and Holly's wonderful comments about the vision of the Bucksbaum and the extraordinary environment at University of Chicago. I think at this point in our world, we're so mindful of how connected we are, the impact of isolation, our interdependence, and what happens when that dependence and interdependence is disrupted. And I think the doctor-patient relationship is such a beautiful illustration of how healing and good come from being in relation to one another and being intentional about that sense of belonging. It's clear that the Bucksbaum Institute is extraordinary. How fun to see the journey, Kay, with you, your family, and the original vision. It's really no coincidence that this is a signature program at the University of Chicago, bringing together the entire campus, people from all stages developmentally, all disciplines, and the full strengths of the university to advance it. it's no coincidence that it has a focus on excellence and disparities and making a difference in real time, but also changing the future. And again, as Holly commented, you've put things in place that just by their nature create transformational change that we'll see over time. And that's so exciting. It's also no coincidence that it's led by Mark Siegler, who, with the support and absolute commitment of a really visionary dean and leaders throughout University of Chicago. I think Ken's commitment to this has been phenomenal. The incredible Bucksbaum family support in seeing this through. It's no coincidence that this signature program has occurred. And it's so fun to see my wonderful colleagues, Arthur and Jordy and Holly and Matt and Angela, everybody in this great work. So I would say that it's been such a fabulous program. I mean, we wept a little bit. I don't know about you. I know Bernie wept. I wept a little bit during his talk. And I think that speaks to the time. The matters that we're talking about are so consequential. They move us so deeply as people. And he brought historical context. And he also made reference to one of my very favorite articles of all time that actually changed my entire career. It was the New England Journal piece by Hasib Aoun about his needle stick, about how medicine turned its back on him with no disability insurance, no health insurance. And it led to 25 years of work in my career looking at healthcare for physicians, medical students, and residents, and elevating those issues. But he also talked about essential workers and our own humility, the special challenges that people of color and people impoverished are fighting with in our world. And I want to thank him also for elevating the importance of peer support and psychological first aid efforts to stand with and support one another. Jay Pinto, you did a great job. I loved your talk about how we can take better care of our communities. And you brought both common sense and academic rigor. And with that equation, trying to bring better health to children is just phenomenal and inspiring. Marshall, I want to just talk to you forever. I've decided I'm getting on your calendar. We're going to have a whole series of conversations. But I appreciated your comments about disparities in the context of chronic illness and then these intersectional identities that is so important to you. And Angela and you with your experiential learning illustration, you were awesome. And I think you gave us a skill that we can all take home. So kudos to all. Nicola, you actually, I loved your talk, and I want to remind everybody of the 6 rules of improvisation that Nicola educated us on. Be courageous, not necessarily fearless, but courageous. Listen, truly listen, which is what Arthur talked with us about. Say yes more than no. That's such a good thing, except for when you're raising teenagers. We'll talk about that later. Don't be clever, be vulnerable. That was such a lovely insight. Trust others, yourself, and the unknown. The only question I would have there is if that's a privileged cognition, that trust, the presumption of trust comes from a place of privilege. And so I want to challenge that a little bit. And yet I think it's a lovely concept. And that the truth is in the moment and in the patient. I thought those were beautiful, beautiful insights. The other thing which you may be surprised, well, I'll say one thing as a psychiatrist, I love that you talked about basically sex, drugs, and rock and roll, how, you know, talking about certain subjects is really hard for everybody, especially for novice, early career individuals talking about these issues. But we really have a syndemic of many things: the opioid epidemic, suicide epidemic in young people, just devastating health disparities, COVID, and now all that we're dealing with mental health and isolation. So that was good. But the thing that I may surprise you is, as the editor of Academic Medicine, I have literally received thousands of submissions this year. And I have to turn down 94% of what we get. And I was an editor for 17 years of another journal, but I don't think I was prepared for basically upsetting 94 out of 100 people that I encounter when my whole goal is to be generative and developmentally supportive. But what I loved about your talk is it reminded me again how hard it is to do work, how hard it is to do educational intervention work, and to thank you for it. And keep going, because you'll get that publishable paper with your statistical significance, et cetera, when you get there. Andrew, I thought your talk about evidence-based strategies in the doctor-patient relationship and how you started there and ended up with COVID and the challenges of the world, I thought that was really very inspiring, and appreciated what you said about feeling cared for. We can have evidence, but the feeling cared for makes such a difference. Daniel, your work on end-of-life care dialysis, in the state of California, we just are right now voting on a proposition related to dialysis and standards, and the differences across different communities and attitudes and concerns there are profound. And then Kevin, this idea of how physician choices can make patients eligible or ineligible for transplants, and how policies might affect standards of care, is brilliant work, and I hope you'll stick with it and see where that model, that set of ideas, can be applied elsewhere. So I just thank you for the opportunity to make all these comments. I would just leave it with, I think you're doing brilliant, brilliant work, but I don't want you to stay satisfied. I want you to be dissatisfied with the current state, and to keep striving for more, keep giving of yourself, who you are, and these unique strengths that you're bringing are bringing us really compelling answers to very hard human questions in the field of medicine. And I'm very grateful for your life effort in this way.
Laura, thank you so much. Our final speaker is Dr. Jordan Cohen, with whom I worked for about 10 years back in the 80s and early 90s. Jordy is now President Emeritus of the Association of American Colleges, at AAMC, where he had served as president, I think, for more than 10 years. He was also the chair of the Arnold P. Gold Foundation. Previously, Jordan had worked and taught at Brown and Tufts, and at the U of C, and at Michael Reese Hospital, and at Stony Brook and George Washington University. Jordan is a member of the National Academy of Medicine, serves on medical school visiting committees at Harvard, University of Chicago, University of Pittsburgh, and at Weill Cornell. Jordan Cohen is a former chair of the American Board of Internal Medicine and was vice chair of the Board of Regents of the American College of Physicians. Jordy, it's a pleasure to welcome you as our concluding speaker. I'll say a few words when you're done, but you're on.
Well, thanks, Mark. I know the hour is late, and I'm going to be. I'll try to be brief. First of all, I need to send you a new picture without a mustache, so you'll see what I look like, President. Well, first of all, coming after my three illustrious colleagues on the board, I really have much less to say. I just want to underscore again the success of the Bucksbaum Institute and the really thrilling recognition of what you've accomplished over these last 10 years. And I think today's symposium was an ample example of the breadth of the kinds of things that the Institute has engaged in very profitably. So I really congratulate you and Kay, of course, and the Bucksbaum family. I think deserve enormous credit for their willingness to invest in this very meaningful work. I really wanted to make two comments relative to what we heard today. First was with respect to Bernie's comments. Bernie noted in passing that one of the students that he remarked on felt that this was the best experience that they'd ever had, having an opportunity to work within this pandemic. And I think that underscores a very important issue. I think I have to say, I have to tell you about my own personal experience as a sophomore or junior in high school. I was in Kansas City, and it had a century-old flood during the time that I was there. And the whole downtown Kansas City area was flooded, and they called upon volunteers to fill sandbags in order to keep the river from inundating the rest of the city. And a few of my friends and I hustled down to the riverbank, and I think for like 36 hours straight, we filled sandbags in order to keep the river at bay. And I've never been more proud of anything I've ever done than having had an opportunity to get personally involved in something as meaningful and as life-saving as that. And so I really resonate with that idea that we should not, we obviously need to protect our students, need to keep them safe, keep them well protected from the risk, but we must not only encourage them, but allow them to express their desire, because I think in retrospect, when they finish their training, you're going to look back on this period as one of the defining moments of their professional development, that they've had a chance to participate in a historic event and had made a contribution to that in a way that's very meaningful. So that was the first point I wanted to underscore. The final thing I wanted to say had to do with Andy Davis's talk, which I thought was spectacular. But I think what we've learned from this epidemic is that there are a lot of innovations that have occurred that we might not have stumbled on quite so quickly had it not been that we were forced to make these innovations. And one of them clearly is telemedicine. Telemedicine, I think, was limping along before this epidemic challenged us, but now it has clearly come to the fore as going to be something that's going to maintain, I think, a strong presence and a growing presence, I believe, in many aspects of medicine going forward. And what that says to me is that for the Bucksbaum Institute, this is a golden opportunity to bring the insights and the commitment and the passion for the doctor-patient relationship and figure out how to keep that doctor-patient relationship alive in the context of telehealth, of tele-interviews. It's a very challenging area, and he touched on some of the challenges involved in trying to be able to read people's body language and get a sense of their mood, and some of the other insights that you can get, which we've traditionally gotten from firsthand relationships with hands-on kinds of involvement. I think we have to learn how to do that, and I'm sure there are ways in which we're going to be able to improve upon how we're doing it presently. But I think, again, as an agenda for the Bucksbaum Institute, I think this is a clear challenge that we have as a center of creative thinking about the doctor-patient relationship. Here's a challenge that I think we need to grasp with both hands and do what we can for it. So Mark, thank you, and the rest of the team. I've so much enjoyed my participation with the Bucksbaum Institute, and I just hope it can continue for another 10 years.
Jordan, thank you. And that's a fantastic idea. As someone who's been on telemedicine for the last 6 or 7 months, the complex areas of maintaining and supporting the doctor-patient relationship are quite different from being face-to-face with a patient. And I think that's a very valuable area to pursue. I want to thank the deep insights from our spectacular advisory board, Arthur and Holly and Laura and Jordy. I want to thank all of the people who attended for this 9th annual Bucksbaum Institute Symposium. The presentations, as you all said, were outstanding, beginning with Bernie and continuing with the other great faculty and the student presentations. I would very much want to thank Kay and John Bucksbaum and Dean Polanski for helping to lead the Institute, and of course Matt Sorrentino, the Associate Director of the Institute, and Angela Pace Moody, the Manager and Director of the Institute, who's always in charge of keeping me and Matt under control and pursuing the appropriate things. Angela, thank you so much. I'd also like to thank our hardworking Bucksbaum Scholars for all the work that they put forth in their research and clinical activities. I'm going to say again my thanks to Kay Bucksbaum and the Bucksbaum family for its continued support of the Institute. Without their trust and support, we would not have been able to achieve what we have in the past 10 years, nor what Jordan wants us to achieve in the following 10 years. Thank you so much. Everybody stay safe and be well. It was wonderful to see you all. Thank you.
Thank you, Mark. Bye-bye, everybody.
Angela, thank you.